Hello, everyone, and it's a real pleasure and honor for me to open this third update meeting from our society, Minimally Invasive Extracorporeal Technology International Society. Despite the difficulties we all face from COVID pandemic, we keep on with our initiatives, and as you all have used, this update meeting is one of our main symposia and meetings that we organize regularly every alternate year, and we try to overcome the situation, and for this we will keep on with this update meeting in the hybrid format that we used to do it even before the pandemic conditions. So with this update meeting, what we try is to have an open board meeting, and as I will present, that needs the key opinion leaders in the technology to be physically here, and the audience will participate through either our website, live media or CTSNet, or with YouTube, and try to send us any feedback, any questions that they might need. So to start with the introduction, I want to thank all the participants that are in person, and I would say a couple of words for our society, which has been founded 7 years ago in 2014. And as you see here, it already has more than 400 members from 74 countries. The good thing is, despite the pandemic, as you see here, we keep on with our initiatives, and we do have increase in our members. Just I want to make clear that this is a group of experts on this society, on this technology, and it is a multidisciplinary, a real multidisciplinary society, which comprises not just perfusionists, but surgeons, anesthesiologists, industry, and other scientists that are dealing with this technology. So, yeah, in in the map that you can see, it's obvious that it's distributed to mainly Europe, but Asia and Northern America picks up, and we hope that we will be able to ultimately expand to all over the world, because what we advocate is a more physiologic cardiac surgery. Throughout these 7 years, MiECT has accomplished a lot of initiatives, among them all these symposia and meetings, and most of them, nearly all of them, have been live broadcast, and CTSNet is our partner lately. And as you see here, it's distributed not just to Europe, but in other countries and in other continents of the world. This is the way that we used to have the meeting, this update meeting, the years that have been passed. Unfortunately, last event was completely online event, a virtual event, MiECT is live, because we couldn't do it hybrid. But as you see here, despite this format, throughout the years, we had a lot of viewers that are interested in this technology. And from the first meeting, 2017, up to the last completely virtual meeting, we do have more than 100,000 views in these update meetings. And just to bring up how popular is our society symposia and meetings, the second MiECT symposium that was in Athens back in 2016 attracted already more than 300,000 views. And this is something really significant, because it indicates how much interest there is around MiECT and its symposia. So let's go for overviewing what you will attend, what you will hear in the next 2 days, today and tomorrow, from this update meeting. So MiECT's seat is, as you know, Thessaloniki, and we do have in this venue this third update meeting, the MiECT update meeting, in collaboration with the local Aristotle University and the CME CPD office of our school. The statute of our society has approved that this update meeting some years ago, 4 or 5 years ago, that this meeting comprises 21 key opinion leaders as faculty. Today, we have 11 of them on site and 10 over web because of various issues that they faced, and they couldn't actually come over despite their willingness due to various COVID reasons. There are also 15 invited opinion leaders that will join us, and we will have, as you have heard, this meeting open for comments or questions from people that they will attend virtually. The main concept is that this meeting will have a very, very specific purpose, and this is to present mainly results. And that's why all the lectures should limit their extent to 7 minutes, and all the commentators will have just 3 minutes to comment or question. Basically, the format of this meeting in 2 days is these 5 big sessions. One is the update on research. As you appreciate, this will be focus on what research was published the last 1.5 years that we have to do this update meeting, and we will have the main messages for the attendees of what's going on MiECT, on this technology. Then we will have our usual industry forum, which we consider very significant, that we do have the industry people with us trying to evolve this technology with them as partners. And the third big session for this year will be the focused update. As you will know, all of you, one of MiECT's big initiatives from the first beginning was the position paper that was published early 2016 and summarized what was the literature and the clinical experience up to 2015 when MiECT took over and defined society, made the guidelines, and what are the recommendations from all the results so far. And so after these 5 years of MiECT's initiatives and all the results from the literature, we should do a focused update, and that is what we will do this in this session. And tomorrow we have 2 big sessions. One is an overview of MiECT in clinical practice from key opinion leaders. So that will be a Class C or a mini review of the literature and the clinical practice that is accumulated throughout the years on MiECT. And we will end up to define what is the COMICS trial update and what is going on from our multi-center study and what we will do onwards. So what I want to emphasize is this distribution of the centers that are dealing with this technology, that are becoming more and more, and there is a lot of interest of what we are doing, mainly focused on this trial, the COMICS trial, which we have published the protocol, and we are now having more than 1,000 patients that have been recruited in the 2 cohorts, the conventional and the mini bypass cohorts. And we will discuss tomorrow what we'll do from now on because of various issues and problems we faced throughout this multi-center study accomplishment. So just to finalize my introduction, I would say that stay tuned. This meeting is hybrid, so most of you are having the broadcasting from CTSNet or our society's site or from live media, and we hope that we will have another fruitful meeting as we used to from MiECT. So welcome you all, in person or online participants, and I really want to thank you for your input so far, and I hope you will have a valuable input for the meeting as well. Thank you all. So, John, I think
yes,
we are ready to start, and you take over as the moderator with Prakash for the first session.
Good. Well, thank you very much, Professor Anastasiadis. It is a tremendous pleasure to be again reunited with my friends and colleagues. I'm very disappointed that I'm unable to join you in lovely Thessaloniki, but as you mentioned, events conspire. So I'm actually joining you from a somewhat chilly London, Ontario. We got a bit of snow on the ground. And as Professor Anastasiadis mentioned, we'll also be joined by Professor Prakash, who will be joining us from London, UK. So we'll start the first session, and what we'll be looking at is really an update on research. So myself and Professor Punjabi will be making comments as appropriate. And we have, I believe, 7 presentations that we'll be hearing about. We'll have commentators for each of these, and then we'll potentially have a few minutes after each paper to discuss some of the issues and implications. So I think with no further ado, we'll start with the first presentation by Professor Anastasiadis on MiECT and safety, with a comment from Professor Rob Baker, who will be joining us from Australia. Please carry on.
Well, thank you, John. And as I opened the meeting, I have the honor to start first for this update on research session of our meeting. And what I would deal with is what about safety on minimal invasive extracorporeal circulation strategy. So what I would say is that this technology has started as soon as the ECLS, early 80s, have accomplished the long-lasting ECMO use. So a closed circuit that was by the patient and not in theaters. And with this concept, the two decades that have followed this introduction of ECMO in clinical practice have focused on closed circuit, centrifugal pump, heparin bonding, and short tubing, so as to develop an upgrade CPB system, which will be more biocompatible. And that's why we had, after 50 years, the early start of mini CPB era, that was early 2000, as you see in this paper from two teams in Regensburg in Paris, and soon after a lot of other, mainly European as well as American, some people from United States joined from the first beginning to have the first trials that were focusing on this technology. So the very first paper started in 2004, and it is from Regensburg, from a multidisciplinary group of people, and focused on this closed type 1 MiECT system. Soon after, the people that dealt with this technology has started to modify their circuits, and they had a lot of custom made, and then from industries some sets that have been grouped to upgrade systems from type 1 to type 4. And this is actually what has been going the last 20 years that are in clinical practice, but especially at the early years and throughout this period, there was a lot of discussion, a lot of concern regarding efficacy and safety of this system. So regarding efficacy, I would say that results have been published, and we have discussed a lot of times about the beneficial effect of MiECT use in clinical practice, and that's why they have been incorporated to guidelines. And by all means, that will be discussed in our position paper later today. But regarding feasibility and safety, there was a gap. And especially I remember myself when I was lecturing 10 years ago, maybe more, 15 years ago, I was kept having questions about safety and some concerns from mainly from perfusionists about the clinical results and the introduction of this technology to their practice. So what we have done is we went to PubMed and tried to record all the papers that were published or been presented in lectures, as you have seen here. And we have selected 10,526 papers that have been screened from this database, and we've reached up to 14 studies that included in qualitative synthesis that were dealing with the issue of safety and feasibility. So these papers are seen in this table here. And as you see, they can be divided into two groups. One is type 1 to type 3 systems, and the other ones, the other 7 papers that are equally distributed, are modular MiECT systems, hybrid systems. So we will go and see in each group what is the concern that they have raised in the literature, and going one by one. You see here the very first paper from Lollert in 2005 had a trouble in air entrapment that was resolved without any clinical consequence. Second paper was 2005 again, type 1 again, and the problem was double. One was air handling, and the other one was low circulatory flow in patients that were big and they couldn't have as much cardiac output from the pump as they would need, just because this is a closed circuit. The third paper is in 2008 and has the same concern that they couldn't reach to high flows with the closed circuits, just because of the inadequate patient's own reservoir. But both these papers have no difference in clinical outcome, no reporting adverse outcome. The next paper is 2009, and it's type 2 as the previous one system. That was dealing with air entrapment in 2 patients, no clinical consequences, that one. The other one is in 2010, randomized trial, type 1 and type 2, and they have recorded some gaseous microemboli, but no clinical problem to this. The other study is 2011, and as you see here, it's type 2, and the concern was about air entrapment, but again, no clinical complication from this. And the 7th and last one is in 2020, last year, type 3 air entrapment in the venous line, and no clinical consequence. So this is actually the overview of these 7 papers. As you see, the main concern is air entrapment, and there was no clinical consequence to this cohort. What I would say is when you go and review this literature, and you go and review each of these papers, all of them are referring to this very first paper from Nollert and colleagues. And what actually is going on here is a type 1 circuit that was utilized for CABG's very early years from people that randomized 30 patients into 2 cohorts. And they had 2 accidental problems. One, air from their venous cannula because of not very well air tightness in the connection. And the other one was accidental air that came into the system just because they had an intramuscular LAD and they had to dig into the right ventricle and they had some air. Both of them resolved without any problem. So actually this is the main issue here, that most of these concerns is when the industry didn't produce type 2 systems when the bubble trap was integrated into the circuit, and then no problem was reported after that because the bubble trap really resolved the air entrapment issue. So if we go to the second cohort on modular MiECT systems, then again, as you see here, the main problem was again either air or some bleeding. And to most of them, nearly all of them, what has been done in these cases is conversion to open. So the difference with this cohort of the 7 studies is that it was immediate conversion to open, and no clinical consequences have been reported. So what I would say is modular MiECT systems really provide a safety net when you operate in all cardiac case mix. And to prove that, we challenged these cases with our cohort in Thessaloniki the last years, and we have recruited 403 consecutive patients with, as you see here, all cardiac case mix. And what we have found out is that we had a conversion rate of 4%. And another 2% when we operate, that was mandatory, when we operate to aortic cuts in redo and dissection aortic cases, when you need to do open distal anastomosis to the arch and you need to do a circulatory arrest and offload the intravascular compartment from blood. So these 4% of cases needed to be converted due to various reasons, as you would see. That is mainly one. But anyway, I will discuss about this. But what I want to emphasize here, that all the other patients, 96%, have been literally operated on a type 3 MiECT system. And the difference between type 3 and when we convert, as you see here in these two cohorts, is in Euroscore. That means the patients that have been converted were sicker. They had longer cross-clamp time, longer CPB time, and higher peak lactate when they have been opened. And the transfusion was much more when they've been opened. And just see in the red line that when we say conversion to open, this is a partial, an incremental time. It's not throughout the case, and it's less than half of the time. So we have to appreciate this design, which indicates that when we say hybrid system, modular, we actually use the closed system. This is the component that is being used in 96% of the cases, and the standby component is being utilized whenever needed and not to the rest of the cases. So if we go and check what has been done in our cases and analyze the results, as you see here, excluding the cases that have been deliberately converted because of arch surgery, all the rest had either air entrapment in 80% of cases, or 15 to 20% out-controlled bleeding due to an accident. And what is the main reason, what's the main procedure for that, is mainly mitral valve, and much less is aortic valve, and the rest, as you see here, is ascending aorta, CABG, or right heart cases. So actually, if I project our results to the other literature results, I would say that we have a much higher degree of conversion. In the literature is reported 2%, we have 4.5% overall, but I would say we have very liberal strategy of converting the system as soon as someone from the team feels uncomfortable. It's not just the perfusionist, it can be the surgeon, for example. And despite this, we still have 96% of type 3 closed system. So to conclude with my presentation, I would say that this skepticism against the expansion of MiECT use was very early years and stopped already the last 5-6 years. And don't forget that most of these cases were operated on a type 1 MiECT system, and that's why I personally, and I believe most of the key opinion leaders in this field, do not recommend ECMO for operating patients. We think that it should be historical, and since there is always the availability from companies to offer a bubble trap into the system, they should go for type 2 from the first beginning. But what is the main message from this review of the literature is there is no clinical event reported so far in the literature when operating on MiECT. On the other hand, type 3 MiECT circuits with the modular configuration provide 100% technical feasibility and perfusion safety. And again, for me, it should be the standard perfusion policy, because modular systems secure safety and ensure technical feasibility. They can be used as hybrid only in 5%, in less than 5% of procedures and partial procedural time, and they can overcome any issue that is mainly air handling and volume management. So this is the paper that we have published. There are a lot of tables and also other data that are accompanying this paper online, and I hope that I made my message clear that there is contemporary no safety issues or concern regarding MiECT use, and also that modular MiECT systems and secure feasibility and safety in cardiac surgery. Thank you.
Thank you very much, Professor Anastasiadis. I believe now we'll have a few comments from Professor Rob Baker, joining us from Australia. How do you do, Rob?
Thanks, John, and thanks, Kyriakis. That was a very lovely representation of the respective safety in this field by the MiECT group. I think it's important to recognise that safety has been a key feature of what MiECT has been about. In the position statement that you published in 2016, you highlighted that safety was incredibly important, and part of the reason for the development of the modular system was the recognition that one system didn't fit all, and the early Type 1 system potentially, did create safety issues for clinicians. And by the advancement to the Type 4 modular system, many of these systems are able to be addressed. So what we're still faced with, we've got the good design, we've got the good research going on. We need to, as you've highlighted, we need to continue to practice toward guidelines. And I think the 2019 European guidelines, there's a number of guidelines in there around safety and also about MiECT. And it's a recognition of the development of MiECT in the field of cardiac surgery and how the community is believing in the commitment to the concept of making MiECT safe. I think the challenges, and I think you highlighted the challenges, are about understanding the variation in our practice and continuing to report it diligently and accurately. And that's a difficult task when there's so much variation in practice. So working towards standardization, continuing the quest for the randomized controlled trials, which I know the group is working extremely hard at continuing with. And over the last few years, there's been a number of small publications. We see the COMICS trial continuing, and I know we're going to talk about that later in the meeting. But I think I'd just like to finish by saying, I think that the commitment of the group to the recognition of safety and the reporting of safety highlights the advances that we're seeing in the support of this technology. Thanks, John.
Yeah, well, thank you very much, both Rob and Kyriakos. I think that's a very good start to this. Safety is obviously of paramount concern now. And I think with having said that, we'll carry on with the next paper, which will be the influence of MiECT on postoperative atrial fibrillation. Again, in the context of safety, as you're all aware, postoperative atrial fibrillation is one of the most significant contributors to early and even delayed postoperative stroke. So I think anything we can do to reduce this incidence is very, very welcomed. I'll please remind the presenters once again, you have about 7 minutes to give us your presentation. We'll have 3 minutes for the commentation, and then we'll have an open discussion for approximately 5 minutes or so. So thank you very much. And now I think we carry on with Professor Ashraf El-Issawi. Ashraf?
Yeah, hello everybody. I want to start straight away to keep track with the 7 minutes. I've tried to keep it simple, short, and hopefully with an impact. So although I cannot sell this paper as an update, it is still the largest prospective randomized study in the field that has atrial fibrillation as one of its main points of outcome. It was published back in 2011. This was a prospective randomized trial that incorporated 500 patients undergoing elective CABG, AVR, or CABG plus AVR. And we had a protocol, a specific protocol of prophylaxis against atrial fibrillation and a protocol for detecting atrial fibrillation, which is of course very important if you are having this as one of your main endpoints. And we had an incidence of 16% with MiECT and versus 24% with a conventional system, which was statistically significant. And this makes up a reduction of 30%. And this is a number that you should keep in mind. Later, when we looked at the data multivariate analysis and looked at for independent risk factors of atrial fibrillation, we found out that the age of the patient was significant, which is repeatedly mentioned in the literature. Another independent risk factor is the type of operation, if we're going to do a CABG or an AVR. And the third one was the type of circuit, which is very important because this is actually the only factor that we can influence. We cannot change the age of the patient nor the type of operation that he's coming for. If we look at the meta-analysis, these are the two most recent meta-analyses, one published in 2015 and the other just published a few months ago. And we see that although not all of these studies had atrial fibrillation as main endpoint, there is a lot of mentioning of atrial fibrillation in the literature. And in that first meta-analysis, which incorporated 3,700 patients, and we see that most of the studies found a reduction of atrial fibrillation in conjunction with a mini system, and that again there is a 30% reduction in the risk of atrial fibrillation when using a mini system. Although in this most recent meta-analysis, some of the studies did not find a significant improvement. There is even one or two studies who had a higher incidence with MiECT. Again, the reduction in risk is something about 30%. So you have to ask yourself, why is that so? Again, 30%. This is a very nice review published back in 2012, looking at the predictors of atrial fibrillation. And here they had a very nice graph showing that the course of CRP post-operatively has its peak during the second to third post-operative day, and then it falls down again, while the incidence of post-operative atrial fibrillation, at least in the cardiac patients, follows a similar course, which puts inflammation as one of the main points that influence the incidence of postoperative fibrillation. But if we look at non-cardiac surgeons, they follow a somewhat similar course, but there is a high difference between those cardiac and non-cardiac patients. So there must be something that we're doing during surgery that has an additional impact. And when they tried to analyze this further, they said that there were obviously intrinsic factors which the patient comes with, which make him more liable to go into postoperative atrial fibrillation than a patient who doesn't come with these intrinsic factors. But in addition, we get an extrinsic triggers focusing on the operation itself, on the inflammation, on sympathetic activation, on oxidative stress, and all these have their peak during the first two post-operative days. And if both the intrinsic factors and the extrinsic triggers push the patient above an atrial fibrillation threshold, then this patient will get an atrial fibrillation while another one will not. And obviously, in this time period, when the extrinsic trigger with a minimal invasive system is more physiologic, the trigger or the push that the patient gets to bypass or to exceed this atrial fibrillation trigger is of greater magnitude, which explains why patients with a mini system get less atrial fibrillation. But the question that we were interested in, that most of these patients returned back to the sinus rhythm within the next few days. And the question was, if the cumulative effect of the intrinsic factors and the extrinsic factors would keep some of the patients, more patients up here, even beyond discharge. So we did a retrospective analysis of 763 patients who survived elective CABG over a 5-year period, and all had preoperative sinus aneurysm and did not have any history of supraventricular arrhythmias or atrial fibrillation. And we looked at the incidence of atrial fibrillation at discharge and the incidence and Holter monitor in rehab. We had the unique situation that over 90% of our patients were going to the same rehab facility, and they all got a Holter monitor within 3 to 4 weeks postoperatively, meaning on the 28th or 30th postoperative day, we had a Holter monitor of over 90% of these patients. And we looked at the incidence at discharge, 3 versus 9%, which was statistically significant. And we looked at the incidence at these 30 days with Holter monitor, and it was again significant, 1 versus 4%. However, as this was a retrospective study, not prospectively randomized, when we look at the patient characteristics, we'll see that age was significantly different between both groups, and the duration on cardiopulmonary bypass as well. And both are very important triggers for atrial fibrillation in the literature. So we did the propensity score matching and with a 2-to-1 matching, and we ended up with 240 patients, or almost 240 patients versus 124. And if you look at the risk factors, there is no difference, statistical difference between the patients. And again, the incidence of postoperative fibrillation was statistically significant different at discharge and on rehab. We looked further for the independent predictors of atrial fibrillation in the whole collective, and we found that again, age, the type of circuit, both were statistically significant for atrial fibrillation on discharge, as well as atrial fibrillation on Holter monitor during rehab. The one thing that struck us a bit was that the duration of cardiopulmonary bypass, which again was repeatedly mentioned in literature, was one of the predictors of postoperative atrial fibrillation, was not significant. So we did a subgroup analysis and just looked at the patients who got a conventional system or MiECT system. And here we found that in the MiECT system, the duration of cardiopulmonary bypass had no significant effect, but when we looked at that subgroup of conventional patients, they all had the duration of cardiopulmonary bypass had an effect. So obviously, the duration of this trigger has an additional effect on the patients, which goes hand in hand with an inflammatory effect. So going from literature to real life, when we decide to go into surgery, we always balance risk and benefit with the goal of reducing mortality and morbidity, as this will have effect on short-term outcome as well as long-term prognosis. So let's imagine we are getting a 40-year-old patient or 50-year-old patient with a triple vessel disease coming for CABG. We decide to go for a complete arterial vascularization because we want to improve the long-term prognosis of this patient. The patient is young, he is discharged on the 8th postoperative day, but he goes home with a new onset atrial fibrillation. Obviously, the impact of atrial fibrillation on the short-term outcome wasn't so great. He is a young patient, and he was still discharged on the 8th postoperative day, but this atrial fibrillation will have its toll on short-term outcome, on 30-day outcome, and on long-term prognosis, because it will need anticoagulation with its effects, thromboembolic complications, heart failure incidents, hospitalization, and the end of it, quality of life. So is this avoidable? We know that we have intrinsic factors. We will not change the age of the patient. The duration on cardiopulmonary bypass, I don't think that anybody is being slower than he can. So maybe we can get a bit faster, but this is not a real issue. We're always trying to be as fast as possible. But of course, we can use the best machine available, and that would be a MiECT. And with that, I would like to conclude.
Good. Well, thank you very much, Professor Al-Asawi. I think now we'll have Professor Antonitsis give a brief commentary.
Yes, thank you. Congratulations, Asaf, for your very, very nice and up to the point topic for discussion. I would like to stress a few points that you have mentioned at the end of your presentation, and then we will have the opportunity to discuss it later on. First of all, during a research that I've done back in 2006, 2007 in Oxford, in a very large series of valve patients operated by Professor Westerby and is published in the Annals of Thoracic Surgery, we have shown that it's definitely patients with postoperative atrial fibrillation have a worse long-term prognosis compared to patients that do not have atrial fibrillation. So it is not a so-called benign arrhythmia as we say it is. Of course, when we want to design a trial, when we want to describe outcomes, we consider the postoperative atrial fibrillation as a minor outcome that does not even affect hospital stay. But definitely it's not that benign outcome as we consider that it is. It's a very, very important reason for readmission to the hospital, and it is also increasing the cost and it lowers the quality of life. And this is not something that we deduce from our thinking. It's actually there have been cost effectiveness and the health economic analysis by the European Society of Cardiology that shows that the cost of atrial fibrillation is significant in patients operated and not operated for cardiac disease. So it increases significantly the cost. It increases the complexity of the disease, so the patients need to take medication, including the oral anticoagulants that are considered to be safe, but they are not as safe. They are also related to bleeding episodes. And also it is, atrial fibrillation reduces quality of life. So I would like to thank you for your very, very nice presentation, and I hope that in the next that during the course of the session we will have time, let's say, to discuss about the potential mechanisms of reducing it. Thank you.
So just let me make two comments. Being a cardiac surgeon myself, I don't want to criticize surgeons, but that's why I put up this patient 40 years old. So the surgeon will always look at his technique and say, okay, what is the best thing I can do? I'll do a complete arterial vascularization. I take both memories, I take a radial artery, and that's the best that I can do. I'll be as quick as possible. That's again the best that I can do. And at the end of the day, that is neglecting that this patient goes home with an atrial fibrillation is a very simplistic surgical view of things. As we're looking for long-term prognosis, I cannot be satisfied with this result. And I'm giving you the tool, the answer, how can you avoid that? Because to be honest, as a surgeon, I don't know what can I do other than being quick in order to avoid postoperative atrial fibrillation. And as I'm telling you, this is out of my hand, so I feel no guilt.
Fortunately, as you have very, very well shown, it's a very, very multifactorial process. So cardiopulmonary bypass and even the surgeon, even the procedure is only one factor. I mean, let's say in Greece, consider that we have sometimes temperatures of 40 degrees Celsius. And we operate in patients in the middle of the summer, and we are used to prescribing diuretics in high doses. So consider that, I mean, it's sometimes you can have dehydration and you have a lot of trigger to atrial fibrillation.
But just one more point, simple point. When we look at the literature, I showed that there are a few studies that actually showed that they had a higher incidence of atrial fibrillation with a MiECT than with a conventional system. You have to go back to these studies and read them carefully and see what type of system did they use. How did they deal with their shed blood? Did they use cardiotomy suction, but still selling this as a minimal invasive circuit? Because in this, the first study that I showed, the prospective randomized study from 2011, only 30% of those patients in the MiECT group got their blood back through a cell saver. 70% of those patients didn't get any shed blood at all. It was too little. It wouldn't justify the inflammatory effect that even cell saver has.
Okay. Well, thank you very much, gentlemen. I think in the interest of time, we've touched on a very timely topic. In the interest of time, we'll proceed with the next presentation. I see that Professor Punjabi has joined us as well from the UK. And I think we'll be carrying on now with an update on the circulation with Professor Gunajan.
Thank the Professor Kyriakos Anastasiadis for this excellent organization, and it's always very nice to be here in Thessaloniki. So I'm going to start giving an update within 7 minutes for the update of microcirculation. So as you may know, for the clinical and experimental biomarkers of the microcirculation, is one of them is endothelial glycocalyx, and has become very much popular in the recent research, although it was found many years ago as one of the key components of the cell, just being about the endothelial layer as a kind of layer just composed of hyaluronic acid and some kind of hydrophilic materials. So it covers the cell layers and really protects the whole cell very much. So it has a lot of functions that have been cited in the literature. So, and it has many different factors that affect and becomes this endothelial glycocalyx dysfunctional. So many of them are really directly linked to the cardiopulmonary bypass, since it's inflammatory, with considering its inflammatory response on fluid overload. So the plasma biomarker is syndican-1. So when the endothelial glycocalyx layer is broken, syndican becomes available in the circulation, and so we can detect and understand the endothelial glycocalyx degradation. So there are many different studies in the last 5 years for the evaluation of endothelial glycocalyx layer in the pediatric cardiac surgery, on the cardiopulmonary bypass, and especially for the fluid resuscitation and a fluid overload. So it's becoming also more popular to evaluate them in the cardiopulmonary bypass in different aspects. So another one as a biomarker is aquaporins, and it's the response of the cell to the fluid overload. So when the cell is healthy, that can compete with the fluid overload and produce aquaporin proteins. So when the fluid is very much overloaded, that the cell cannot handle, then it becomes not possible to produce any more aquaporins. So we also measure them in the serum and also in the microscopy. So we did a publication on minimally invasive circuits on minimally invasive cardiac surgery and evaluated all of them. So when we try to update in the current literature, this is one of the largest meta-analysis on the effects of the cardiopulmonary bypass on microcirculatory disadvantages. So they reviewed 277 studies and just focused on 19 of them. And then as a result, they clearly showed that cardiac surgery with cardiopulmonary bypass impairs microcirculatory perfusion. They demonstrated them by functional capillary density, proportion of perfused vessels and perfused vessel density, and total vessel density. So they're all indirect measurements done on different parts of the body during cardiopulmonary bypass. So in our hospital, we started a small study to understand the comparison in between MiECT and the conventional circuit with the effects on microcirculatory status of the patients by quantification of endothelial glycocalyx and aquaporin proteins. So in 100 patients, 50 each, we compared the conventional circuit with the type 4 MiECT. And we also checked for the serum biomarkers, aquaporin levels by PCR, and syndican levels by monoclonal evaluation. Also, we just have samples, and then we studied them in the lab. So this is our MiECT circuit, type 4. And in the early postoperative period, with respect to the clinical aspect, we don't see any clinical differences in between these two groups of patients. But from the point of microcirculation, as seen here by the syndical levels. Let me show, yeah. So as you can see, so syndical level, when it's high, as you know, it means there is a degradation of the endothelial glycocalyx layer. So it's before surgery, baseline, after cardiopulmonary bypass, and in the ICU. So as you see, after cardiopulmonary bypass, the syndical levels is higher for conventional circuit, significantly higher. And aquaporin levels are also significantly higher in MiECT group. That means MiECT group can respond to volume overload since it's not unavoidable for MiECT circuits. So in conventional group, the secretion of aquaporin proteins is comparatively less. So we also demonstrated them microscopically. As you see, this is a conventional circuit. So when the picture is bright, it's not good for endothelial glycocalyx because that means the layer is degraded and the syndican is out, so we can dye them and it becomes bright, so it's bad. So this is the syndican evaluation for MiECT circuit. As you see here, the picture is brighter, so that is significantly difference with the endothelial glycocalyx shedding. On the right side, you see the aquaporin response. This is the edematous picture of the conventional circuit that the cells cannot compete with the volume overload. And in this picture, you can see cells much better to compete with the volume overload. So the conclusion, in this small study, we somehow demonstrated that is clinical plus in the lab, that MiECT circuit is very much protective with respect to protection of the long-term microcirculation. So we are now doing some much more studies on trying to understand the effects of methylene blue on the protection of the disturbances of microcirculation. And also we are working on the mitochondrial function, mitochondrial impact on protection of the macrocirculatory level. So thank you very much.
Good. Thank you very much, Serdar. I think Cam Ince is available to make some comments on the implications of this very interesting work. I have a few questions myself.
Good afternoon, ladies and gentlemen. My name is John Ince, and it is indeed a great honor to make a comment on the interesting presentation done by Professor Günaydın from Ankara. And indeed, I would like to thank very much to Professor Anastasiadis and for inviting me to present this commentary on the MiECT conference in Thessaloniki, where I would very much have liked to have been. Unfortunately, I am in Bologna in the lounge giving this commentary to you. So the research described by Professor Günaydın, which is indeed very, very interesting, because it really looks at cell physiological responses to the use of MiECT over conventional extracorporeal circulation. And once more, we see from a completely different and innovative angle the impact of having to use excessive heme dilution. And of course, the prime aim of clinical intervention is not to do harm. And here we see very clearly that using large amounts of crystalloid fluids in conventional extracorporeal circulation causes indeed harm, whereas the use of MiECT, where much less fluids are used and microcirculation is much better preserved, as we have shown in previous studies, is really a method which can keep the integrity of the cardiovascular system much more intact. They did this by looking at two interesting aspects of endothelial function. One is the presence of aquaporin, and the other is the use of the marker for the presence of the glycocalyx, the shedding product of the glycocalyx when it gets disturbed, which is the syndican 1. And they both found that actually using MiECT, the levels of syndican-1 showing glycocalyx degradation is much higher than in the MiECT, and also showed that in the MiECT, the aquaporins were a lot better preserved. So this is very important because the importance of preserving the glycocalyx specifically is it is the prime component of the microcirculation which allows the vascular tone to be altered depending on the flow of the blood in the microvessels. It is, as it were, the transduction which can feel the shear stress and adjust the tone of the vessels to match the oxygen supply with the oxygen demand. So it's the key subcellular component which regulates autoregulation. So it is well known that providing extra fluids can actually damage this particular important component of homeostasis. And Professor Günaydın and colleagues have very elegantly shown that the use of MiECT actually preserves much better the glycocalyx than does the use of conventional extracorporeal circulation. Regarding aquaporine, I must be frank and honest with you that I find this a very interesting result. Indeed, one would not want such a molecule to be depleted as they showed, but actually what its function is in preserving homeostasis, I think still needs extra investigations. But what stands is the very important result regarding the raised syndican-1 levels in the conventional extracorporeal circulation, which are preserved with the use of MiECT. And I want to congratulate Professor Günaydın for this very, very nice cell-physiological investigation in a very, very clinical arena of cardiac surgery, comparing MiECT with conventional extracorporeal circulation. Thank you all for the opportunity to allow me to comment on this interesting study, and I hope next time I will be among you to enjoy Thessalonica and of course especially the conference being organized. Thank you very much.
Well, thank you very much. That was I gather, a pre-recorded commentary, but I think it was a very important insight into the implications of these phenomena, this loss of the endothelial glycocalyx. And we've certainly been making some interesting observations in conventional bypass about the implication between amount of volume administered, duration of bypass, and progressive reduction in peripheral vasoreactivity. So I think we're starting to get a much better insight, thanks in part to this very important work. And I think Professor Punjabi, do you have any comments to make, please?
Thank you, John. Sardar, as usual, pleasure to listen to you, and also congratulations to Ashraf for the two. I think what you've shown really is a clinical and a basic science support that is so crucial. And it sits very well because if you just 4 weeks ago, a manuscript has been published in European Heart Journal on a pericardial window, reducing the incidence of postoperative AF. But that apart, the mechanism, if you see, is all to do about the inflammation, and mechanism is all to do with the residual and postoperative inflammation. So I think this is so crucial. Highlight, emphasize, and really focus on the systemic inflammatory response and the reduction of the various components that we see which are detrimental. And I fully agree that AF is not a benign, even if you turn to sinus in 6 weeks' time, the intervening period does have deleterious consequences. And we know that atrial fibrillation, short or long-term causes, is one of the main causes for heart failure. And we are seeing so much of functional impact now. So first of all, apologies for being late. Congratulations. Thank you for the opportunity. And it's a pleasure to be here. Thanks.
Well, thank you very much. I think in the interest of time, we'll carry on. We now have Dr. Mark Bennett, who'll be talking about, again, something very important, optimal venous cannula design with the commentary by Cyril Sarek, the chair of perfusion in Toronto, if Mark's available.
Good afternoon. Thank you, Professor, for your invitation. I'm delighted to be able to address the research regarding venous cannula design and venous return as they relate to the aim of MiECT to deliver a more physiological perfusion. We know that arterial inflow and oxygen delivery are fundamentally linked to venous return, and yet despite this close relationship, there is little research that specifically addresses venous return. Having said that, all research to do with MiECT that addresses oxygen delivery, the generation of gaseous microemboli, and I will show you how this is strongly related to the microcirculation, are all fundamentally linked to research around venous return. Venous return is determined by the mean systemic filling pressure and the resistance to venous return, and the downstream gradient is generated by the centrifugal pump. But if the centrifugal pump is too high and the mean systemic filling pressure low, as you can see here with transesophageal echo, the IVC collapses intermittently during bypass. And this goes back a few years, but our research showed that in a standard MiECT circuit, the average cardiac index may be lower than with a conventional circuit, albeit at a reduced hemodilution. And there is increased flow variability because of that intermittent collapse. We then went on to study the differences between 3 commercially available venous cannulae, and there was little difference in the flows, but they did seem to have a difference in the generation of gaseous microemboli, the clinical implications of which are yet to be fully determined. A further study that we reported to this meeting last year showed the influence of running an infusion of norepinephrine, and in the pressor group there was an increased flow, an increased oxygen delivery with a less negative venous line pressure, and most importantly, a marked reduction in extremes of negative pressure in the venous line. So how do we take it from here? Well, if we wonder what happens when there is low, no, or stagnant flow in the IVC intermittently, even during a bypass lasting an hour or two, we can look at some other literature that is now concentrating on the subject of venous congestion and backflow into the relatively low pressure sinusoids of the liver, and even back further into the portal vein affecting the pre-portal organs, all of which are far more influenced by CVP or venous pressure than they are by the MAP, may have important effects on the outcome of patients if we can't avoid intermittent IVC collapse. So here's a TOE image of the IVC shortly after starting bypass. There is only very slight fluctuation in the IVC, but in the portal vein on the right, the flow is almost monophasic as it should be, the other side of the liver sinusoids, and this is how it should be. But later on during bypass, the IVC begins to collapse and the perfusionist will experience this as chatter. And the next thing you see with color flow Doppler is the significant effect that is having on the velocity of blood entering the venous cannula. If we do Doppler of the portal vein, the color Doppler shows this intermittent hepatic vein flashing at the top, showing that there is intermittent flow, but also the other side of the hepatic sinusoids, the flow in the hepatic portal vein now becomes biphasic, which is a suggestion of venous congestion. So does it matter over an hour or two on bypass? Well, we went back to the venous cannula data and we looked at how the ALT post-bypass increases depending on the flow variability that we measured, and there was a slight but not a massively significant difference in ALT depending on flow variation and the degree of marked negative pressures. So finally, is there any research which can address how we might address this in the future with our colleagues in technology? Well, friend of this society, Yuri Ganashuk and Antoine Simons in Maastricht 10 years ago published this paper, so I'm taking you back a little bit. They measured what was called the dynamic flow index, that you do 10-second decreases of 100 revs per minute on the pump, and you do 3 of them, and from that you can draw a curve which gives you an idea of what they call the drainable volume. If the drainable volume is low, then the pump automatically can perform a decrease in the pump speed, which releases the IVC, and then they ramp up the flow, approaching normal again. They compared that on the far right with a pressure servo and a flow servo system. And in a model of hypovolemia, where the baseline flow and venous line pressures are shown on the far left, you can see that they managed to get the flow to within 85% of the baseline flow compared to the other experimental models. And importantly, the negative venous line pressure was just -9 millimeters of mercury in this model of hypovolemia, where in the other models there is significant venocaval collapse. So in conclusion, the research that is out there suggests that we can begin to measure what the drainable volume is, and there is now a good suggestion about how we might develop this with our partners in industry to achieve a more physiological perfusion even than we have. Thank you very much.
Well, thank you very much, Mark. I'd just like to make a brief comment. We have certainly observed similar issues with the brain. And it's a bit of a misconception that during bypass, the primary determinant of brain perfusion is the mean arterial pressure, because venous hypertension is an unrecognized but significant source of cerebral compromise, and we see reduced brain sats and some adverse outcomes. So very important to focus on the venous side of the circulation. I think now we have Cyril Starek. Mr. Starek will be making a few comments from the perfusion perspective.
Yes, that was a very good talk, Mark. Appreciate it. We know that one of the challenges of MiECT is certainly able to obtaining calculated flow, and I think we need to reassess the conventional thinking of a flow index of 2.4. Certainly, cannulas that we use for MiECT have been designed for conventional cardiopulmonary bypass. So I think we really, I think adjusting flow or automatically adjusting flow based on these negative pressures is very, I think it's a very good idea, and it's very innovative. So I'd like to see more on that. But we know that cavitation is a major issue, and I think we really need to start looking at designing cannulas that are designed for MiECT and have that cannot get cavitation. Yeah, thank you very much.
So one sentence which really addresses both of those comments is that we have a CVP line in all of our patients. So we are able to monitor the SVC venous pressure, but the IVC pressure is an unknown largely. And the second point is that you need an automated way of monitoring it, such as the deliverable volume or the available volume as described in that paper, because that marker, that index, was showed that the patient was, in brackets, empty before there was any suggestion to the perfusionist that the venous return was poor. So, thank you.
Good. Any other questions or comments from the panel or our online audience? And well, thank you very much for that. Again, I think that's a very important component of cardiopulmonary bypass with, I think, several relatively unrecognized complications attending such venous hypertension. So we'll carry on now with the next presentation, which will be an update on coagulation management by Elena Agiriadou and colleagues from Thessaloniki. So please, Elena. Looking very forward to your presentation.
One of the major clinical benefits of MiECT system is the impact in coagulation and need for transfusion. And this is clinically measurable. I'm really happy to have patients operated in MiECT in OR. In this paper, we presented our strategy for point-of-care coagulation monitoring in cardiac surgery, and we introduced our institutional protocol. We support the use of MiECT in all cardiac case mix, if possible, or at least in high-risk cases for postoperative bleeding, such as emergency cases, long-lasting procedures, or surgery on patients with antiplatelets or DOACs. The concept is to monitor and effectively treat specific coagulation disorders instead of activating the panic mode of massive use of blood and blood products and factors so as to optimize coagulation in advance and achieve a more physiologic cardiac surgery. This is what we advocate, and I will present our concept in the next two papers from our ongoing research of our team on coagulation during surgery with MiECT. The first study that I will present evaluates the platelet function after cardiac surgery when operating on MiECT. Point-of-care coagulation monitoring was applied to all of our patients, and the primary outcome measured was the alteration in platelet receptor function perioperatively. We know that in the surface of platelets, there are a lot of type of receptors. Three of them, they can be measured with aggregometry, with platelet function test. And in this study, we assessed the platelet function of 2B3A receptors and to ADP receptors. From the case mix of our patients, it is obvious that the cohort comprises high-risk patients, higher than the average cases, since GABIT patients account for less than 50% of the total patient population. We found only 7% reduction in ADP receptor function test perioperatively. This type of receptor seems to be very important, has a strong association with postoperative bleeding. On the contrary, the platform study found a significant deterioration in platelet function after cardiac surgery using the conventional cardiopulmonary circuits. The platform study results may be translated as the background, the common scenario of postoperative bleeding after cardiac surgery, especially nowadays in the era of operating on patients in the modern anticoagulant drugs. On the other hand, our study highlights the significant benefit as far as platelet function integrity after cardiac surgery when operating on MiECT. And the conclusion from this study was that MiECT is a platelet preservation strategy. The second paper that I will present describes the preservation of coagulation integrity in cardiac surgery procedures on MiECT. This is our protocol, and I would like to point out the individualized heparin management and heparin level guided protamine titration. Rotational thromboelastanometry testing was performed before and during cardiac surgery, and we follow this protocol with minor changes the last 10 years. And in case of bleeding, point of care guided transfusion protocol, it is implemented. And this is our patient cohort. Also in this study, the Gabbage patients were only 38%. The other cases was complex and valve surgery. And this is the parameters that we measured. We measured fibrinogen preoperatively and after ICU admission, platelet count preoperatively, and another parameter from the thromboelastometry data, it's the platelet component. It's a parameter describing the clot strength. It's a parameter describing quality of the clot. It's indicative of platelet function, and this could be derived from the difference in maximum clot elasticity between some parameters measured with thromboelastometry testing. It is an index of clot quality, and we found that it was preserved in our study compared with preoperative values, and this is a significant and very sensitive finding. From this results showed that despite the significant reduction in fibrinogen levels compared to preoperative values, and despite the significant also reduction of the platelet count, the elasticity was preserved throughout surgery. And the clinical outcome from this study is minimal bleeding. So the majority of our patients were classified in class 0, which means minor bleeding, less than 600 ml in the first 12 hours. And the majority of our patients were completely transfusion free. And of course, a zero rate for re-exploration for bleeding. Surgery on MiECT minimizes the need for RBC transfusion. Only 26 of our patients needed RBC transfusion, as well as you can see, zero need for plasma, zero need for platelet, zero administration of fibrinogen, and because of microvascular bleeding and after thromboelastometry testing, 10% of our patients needed prothrombin concentrates complex. So in overall, from our research, it is obvious the protective effect of MiECT on coagulation and the key role of point-of-care monitoring so as to optimize the results. Thank you.
Good. Well, thank you very much, Alina. I do think we have a commentator from Mr. Erdoes.
Thank you, Dr. Merkin. Thank you, thank you, Alina, for this nice presentation. I completely agree with your comments. I have only two remarks. I'm a fan of point-of-care testing of coagulation during operation, and I'm also a fan of platelet function testing. But I would like to suggest that patient platelet function testing is very problematic during the intraoperative period, and platelet function testing is only recommended at the moment for the preoperative period in certain patients. And With regards to the point of care testing, we should be aware that there are many drawbacks of this testing. So they cannot detect DOACs or factor 13 or for Willebrand disease or low molecular weight heparin. And it is also very difficult to predict bleeding. And also with platelet testing, we don't have at this time clear trigger and target values for platelet transfusion. Just to mention that the Society of Cardiac Anesthesiologists just released the new patient blood management guidelines. And I think with MiECT management, we could be even better and even more restrictive with blood products. So we can go lower to a lower threshold for blood product administration. And also, I think patients receiving MiECT do not really need blood product transfusion because of the beneficial effects of this circuit. Thank you very much.
Good, thank you. Any other questions or comments from the audience? I was intrigued to see that you're using a tranexamic acid on a routine basis. Is that for all your cases, Alina, or is that primarily for the higher risk patients?
I use tranexamic acid in all cases as 2 bolus doses, one after induction and the second after protamine administration. And I would like to add something to Professor Erdo's comments. So thank you very much. We measured twice platelet function, one preoperatively and the second one after protamine administration. And I totally agree that concerning the question when we have to transfuse platelets, this is really the gray zone, because the algorithms, they don't give us, they don't propose a certain threshold according to the results of the glycometry when we transfuse. So the only recommendation is transfuse in case concerning the platelet count, but concerning function, it's not validated. And that's why I believe that a lot of cardiac anesthesiologists, they transfuse platelets that the patient does not really need platelets.
Thank you.
Completely agree. Yeah.
May I quickly add another, if that's okay? Thanks. I thoroughly enjoyed it, Alina. Just in terms of the use of preoperative antiplatelet and various other agents, particularly in the coronary group, I presume you factored that and may not apply to all the patients, but what would your comment be and the influence of that in the preoperative point of care testing during bypass and then the postoperative point of care testing? Because I think that is one of the arguments that is used quite a lot by the postoperative surgeon and anesthesia combined to transfuse platelets.
If I understand right your question, do you ask if we have to do platelet function test in every patient that decide the time of surgery according to the results? This was your question? Or?
No, not necessarily. I just wanted your comment or your view on the use of preoperative antiplatelet agents, particularly in patients going for revascularization surgery.
We normally proceed with aspirin, and we stopped clopidogrel 5 days ago, and we follow the recommendation. But this is really problematic with the new DOACs, and that can be measured with the usual thromboelastometry devices.
No, and the impact of that in your postoperative study and the study of assessing platelet function.
MiECT offers an advantage, so preserves platelet function, and comparing to the conventional system, I think that platelets are very well the platelet function is well preserved compared to conventional.
Well, exactly. I think that's a point that I was trying to emphasize also. The damage is less. Sorry, thanks.
Damage is less, yeah.
Good. Well, thank you all very much. I think this has so far been a very good session. We have one remaining paper, and then I'd like to invite everyone to join us for probably about a 15-20-minute discussion, open discussion and comment on the papers that have been presented. So lastly, we'll follow up here with a presentation on myocardial protection strategy by Mr. Jenny from, I believe, Scandinavia. There we are.
From Bern, yes. Can you hear me, everybody? It's okay. Can you hear me? Can I start with the presentation?
Yes, yes, very good.
Okay, okay. Good evening, everybody. Unfortunately, couldn't travel because we have some positive COVID cases in the staff, so I had to stay in Switzerland. But thank you very much for the invitation. I really feel happy. And now I will quickly start with the presentation. In the beginning, I will have some general remarks regarding myocardial protection. Of course, focused on MiECT, and then special on extended surgery during or using MiECT. Let me start with a short systemic review of, which was published in 2015 from Ferguson et al. And they tried to answer the question, or they ask, is there an evidence in the myocardial protection? And you know, they found a few randomized clinical trials which compared commonly used cardioplegic solutions. And I think that is still relevant nowadays. And they also saw that found out that numerous retrospective studies often show similar intraoperative and postoperative outcomes. And it's always an issue that surgeons' preference is still occurs. Of course, cardioplegia should be better investigated. That is clear. Perhaps we will get one day evidence. And also multiple factors play a role for myocardial protection. The problem in the past was always we were divided into two groups. So one group was the believer or the follower of blood plagia, the others for crystalloid plagia. And you know, we use in 70% Buckberg plagia in our clinic, and of course, we also use others. So I think it's a bit pity that we just commit to one group, and that it's really old school, because everybody will find some data will fit with his plagia, because both are good plagias we have more than 30 years experience with. And I think another way we have to follow nowadays is which is recommended by our societies, the EACTS and the ECTA. What they recommend with a 1C, I think it's really interesting. They say we do not have to be fixed on institutional cardioplegia solution. We have make decisions based on clinical condition and procedural complexity. But it's one thing I miss really here. They do not mention the perfusion strategy. And I think it's really important that we take the perfusion strategy into account, because it's completely different if you use a conventional heart-lung machine or if you use a MiECT system. Because remember, the original idea from MiECT was clear: minimize artificial surface, so it will not fit if you use a cold blood cardioplegia, which with all the stuff around, or if we have to minimize priming volume and then we overload the patient with a Brettschneider solution. So what we did in the past, so as we started with MiECT 20 years ago just for CABG, we adapted or we developed a solution, the so-called CardioPlexol. I think the ingredients are not a secret anymore. It's potassium, magnesium, and procaine. And we give normally a 100 milliliter initial dose. We have to repeat it after 45 or 60 minutes with a full dose or half dose, and it can be extended until forced administration. But to be honest, I never saw in clinic. The advantage is that it's a very simple administration. We do not need additional devices. We have great experience in the field of CABG, But really, to be honest, we do not have data for more complex heart surgery. And if you have to repeat it several times, it becomes relatively expensive. And let me go a step backward. If we see a type 1 or a type 2 during CABG, we always see some continuous flow in the coronaries. It can be disturbing for the surgeon, but I'm really sure or assume that that can have a positive or a beneficial effect on the myocard. So I assume, or I'm pretty sure, that MiECT himself has a protective effect on the myocard. And the question now is, if we go to other procedure, if we interrupt this flow, for example, do we lose this effect? That will be important for if we go for extended surgery. Because you can see that again, Kyriakos published that in his review in 2013, that we have favors for MiECT concerning postoperative myocardial infarction. And okay, the most studies were operating by with CABG, and I know they all use different cardioplegias. It can also be a sign that the MiECT itself has a good effect on cardiac protection. So if we go further, I think we have to look for a cardioplegia which fits more with the requirements for open heart surgery. And that, of course, microplegia, I think it's the dysplegia that fits really. And we also have enough data that microplegia works. And I show you here one study, and the other is again from Ferguson et al. We can see as well a superiority between microplegia and blood cardioplegia. I'm sure that all the participants here in our session here, they use Califiore. It's nothing new. And I took here the example from the beginning days in Regensburg. They started with Califiore. I think they continue with Califiore, and some clinics they modify their Califiore, as the guys in Basel are doing. They modified Califiore, and what they use, and I think that is really interesting. They use this myocardial protection system to have a better or accurate administration of the cardioplegia. That will help, I hope so, in the future if we will make studies. And I think that's absolutely needed, because I can imagine that cardioplegia for type 1, for CABG, it was a bit a side note. And now I can really imagine that during extended surgery, cardioplegia becomes a really a hot topic or a central note. Okay, the only disadvantage from this system is a bit the console, which is quite expensive. But they told me after 100 cases, they are in black numbers. Okay. What they also did, they did a study. They compared our microplegia with our cardioplex. And to be honest, I show you this study not because I'm happy about the result, because they have better results for their microplegia concerning troponin C and creatinine kinase and creatinine kinase myocardial type, and short stay, length stay in the intensive care. But that is not the point. I think the important thing is that they started now, and it's one of the few studies, I think I couldn't find 2 or 3, perhaps you can correct me after, which compared cardioplegias in a mini bypass system, because it was never done. And I'm really sure, I'm pretty sure, if we continue to penetrate more extended surgery with our systems, we need to think about the ideal cardioplegia. Another example here, the last one is from Pascal in Hasselt. He has different requirements because they practice MiECT, and for MiECT, of course, they prefer to have a single shot cardioplegia for longer arrest. And type 1, type 3, and type 4, they enable really the use of perhaps more specific cardioplegias. Now, as to discuss, I think the choice of the cardioplegia has to be based on clinical condition, procedural complexity, and perfusion strategy. Different requirements for cardioplegia between MiECT and CC. Micropagia seems to be, I think it seems to be the promising technique for extended surgery by using MiECT. We have a huge lack of data concerning myocardial protection during complex surgery by using MiECT, and more MiECT specific recommendations concerning myocardial protection are needed. Thank you very much.
Well, thank you very much. I think Professor Punjabi would like to make some comments. Oh, you're
Sorry,
muted.
thank you. This is very, very interesting. And I think your point about complex procedures and microplasia would be quite significant in trying to understand the benefit and expand on that fully. The question really is to understand myocardial protection, assessment of individual ventricles for protection, in terms of the basic science aspects and angles. What would you suggest would be the best way to look for that?
We need data. I think what we have to do is to find the data, and that was not done in the past. You know, what we would do, and hopefully will do in the future in Bern, to try to compare different cardiopathias and to create this data. I think that's the only way we can go. I'm not sure if you're going to go back to the lab and to make basic research concerning that. We missed that a bit. I remember as we started with CardioPlexol, we did animal testing, and sorry, it was really an error we did. We just made 15 pigs, for example, and that was quite wrong. So now we're in clinic, you know, we're full in clinic, and now they get to go backward now to do the step backward to give the proof in pigs. If we did 6,000 patients, you know, that's a bit the problem. Now, how we do it better if we go for more complex cases.
Thank you. Yeah.
Well, I'd like to thank all the speakers. I think we've had a very good session so far. I'm sure we have a number of comments to come from the panelists and from our online audiences. But if you don't mind, I'd like to take the prerogative and just kick off. I was intrigued by all of the talks, but particularly Professor Gunajian, because I think looking at the glycocalyx and the implications are of fundamental importance as we begin to understand the mechanisms for some of these significantly beneficial effects we appear to be seeing in the literature associated with MiECT. Cedar, have you looked at concomitantly? I know there's studies that have looked at the inflammatory response. Have you been able to make any correlation between the glycocalyx, better preservation of glycocalyx and inflammatory markers? And have you done any studies looking at vasoreactivity of the microcirculation?
Thank you. Thank you, John, for the question. So that's a very bright idea, and we just started to compare, including the inflammatory response, and we are also doing the experimental study in the lab for the vasoactive response, comparing MiECT versus conventional circuits. It's an ongoing study now.
Yeah, I think that's, again, I think that's of fundamental importance. And similarly with Professor Incha, his comments, the ability to preserve the microcirculatory vasoregulation, I think is of fundamental importance in optimizing end organ perfusion. So I think that's very important work. And in similar vein, I think Mark Bennett's comments about venous hypertension are also of fundamental importance. So any other comments from the panelists, please?
Well, John, if I may have a question and a comment. First, I can take the opportunity of having with us Rob Baker from MiECT. And I want to ask him regarding my talk on safety and feasibility. So I have been to MiECT, as Rob's know, and I have discussed with a lot of perfusionists in the States, Australia, Canada, and I want to ask for his opinion regarding the applicability of MiECT systems to this society. We know that you follow the STS database, which indicates that it's still significant MACE after cardiac surgery. So what I have implied is that there are three major issues regarding this technology, that all of them have been solved. One is feasibility, the other one is results, and the third is safety. So I would ask Rob, is it one of these three parameters, or it is the complexity that makes, let's say, hesitant the perfusionist in MiECT and not apply this technology so far? This is the question.
Thank you very much. I just want to start off by saying I don't represent MiECT anymore because I've been president of the Australasian College, Australian and New Zealand College of Perfusion for the last couple of years. So I've minimised my role with MiECT, but I think your questions are highly relevant because we're all trying to understand what are the barriers to the adoption of MiECT. And I've certainly seen 18 months ago, my centre was, poised to go down the pathway, and obviously the worldwide COVID-19 situation, put a hold on that. But I think you phrase it quite well. Is it feasibility? Is it results? Is it safety, or is it complexity? And I'll probably take you back to Ashraf's presentation when he was talking about AF, and I thought that he really highlighted, that it's not a benign outcome of cardiac surgery. It's something we really have to consider that is highly important. But the focus I wanted to put the spin on in this conversation was he brought the conversation back to MiECT isn't MiECT. And what I mean by that is he was talking about how the reporting of MiECT is in our literature. And he talked about how shed blood was handled in a number of different studies that he was reviewing, and that he couldn't really, he wasn't in a position to really be able to interpret some of those results in terms of, was it a MiECT effect or against conventional bypass, or was it a type of MiECT or a variation of MiECT? And that to me is probably the largest barrier that we have to the adoption of MiECT more broadly, is that we still don't have in the literature a base that we can really solidly reflect on. We've seen this a number of times in the past, and John, you'd remember that in the Key West meeting days, we worked very hard to get a consensus on how to talk about the inflammatory response. And a paper by Clive Landis tried to address that. And more recently, we've tried to talk about, from a perfusion perspective, how we might report blood management. And a paper by Donnie Lukowski presented a consensus view on how to report, in respect of blood management during bypass. And I think that as part of the focused update that you're going to talk about later in this meeting, I think it's really incredibly important that you put a significant degree of focus on how you report the work that's being done, because that is how we're going to change the adoption of MiECT on the broad scale. The results are fantastic. If you look at the most recent publications over the last couple of years, there's 3 or 4 really nice quality, small randomized controlled trials. I think earlier this year, you published an update on where the COMEX trial was at. That's all coming, and there's work continually out there to guide the community, but we're still looking for that clear understanding of what we're talking about. And I think that until we can really define clearly for the community what is being reported, we're always going to have a barrier to the adoption of the technology. Thank you.
May I respond, John?
Yes, please. Yes, I think this is open discussion.
So if you focus, Rob, on results and you exclude all the other parameters, complexity, safety, feasibility, that makes me happy. So, well, you focus on results on inflammation or interpreting results from dispersed protocols, methodology, and so on. But I would say that results are there. They have been already integrated into the guidelines, and I can give you a couple of examples. Transfusion is unanimously accepted that the best PBM is MiECT. First. Second, Helena presented results, and this is also something Gabor admitted. Whoever is using the MiECT systems finds that bleeding is less. Third, organ preservation. Hans-Jörg already mentioned about the heart, but all end organs are well preserved from all studies. There is neither of the studies indicating at least the same or inferior, all of them indicating superior. That's why the joint guideline in Europe, MiECT, EBCP, and IACTA admitted that MiECT is biocompatible, a more biocompatible strategy. So with this, if results are there, of course, I appreciate that this is not a multi-center randomized trial as we wait for COMEX to give results. But still, if you want to follow results or to base on the guidelines, I would say that it's easy to at least to start thinking of practicing on MiECT. And even though in Europe we have 20% penetration, in other countries there's less than 2%. So without working towards this, I really do not know why people are waiting the last 10, 15 years and not adopting at least, to simple cases, cabbage. I don't say 100% cardiac case mix. It doesn't make sense to me, sorry.
Yeah, look, I mean, you make a great point, but the evidence is lagging. We are seeing guidelines being written to support the use of MiECT, and that is what will eventually get MiECT into a broader adoption. But not all of the guidelines are strong guidelines at the moment, and that's I can only reiterate that the other way of building that evidence base, if we take the trials and the publications that are very positive, the other way to build on that is, of course, by having registry data. And we don't have a huge amount of that either. But look, I'm not disagreeing with you that the evidence base isn't continually growing. But you're asking me the question of why isn't it being adopted? And I think the biggest barriers are what is in those publications in terms of being able to compare the exact the circuitry that's being used, and that's where I think you can gain strength by addressing in this update.
Thank you.
Good. Are there any other questions or comments from the panelists or any of our online viewers?
If I can comment, John, I'm Polychronis.
Oh yes, please.
Yes. So I would like to focus on the issue of the venous drainage during kinetic-assisted cardiopulmonary bypass, and I would like to ask Mark Bennett. So which type of cannula would you prefer, the two-stage venous cannula or the three-stage venous cannula? Because this three-stage venous cannula, as Wim knows very, very well, is suited, let's say, better for kinetic-assisted venous drainage, as long as we know that with kinetic-assisted venous drainage, we need to have, let's say, a smaller diameter in order to avoid the suction effect and the cavitation that this could create. You said that with the largest three-stage venous cannula, you found gaseous microemboli in the circulation. Apostolos Veliopoulos is very, very well accustomed to a three-stage venous cannula used in minimum invasive evaporative circulation. So what is your view? Which cannula would you prefer, two-stage or three-stage, and why?
It's multifactorial because the internal lumen of the cannula is one factor. The number of orifices draining which may not become obstructed by a collapsing IVC, is a second factor. And the turbulence that generates, again, has to be played off against the flow. So it depends which is the more harmful thing to the patient. Is it that you may have intermittent low flow, or is the gaseous microemboli a more harmful end result? And I'm afraid I don't think we know the answer to that, because even microemboli of a very small size may be harmful to the patient, and despite filters, they may cross into the arterial supply. So there are probably still more questions asked by our study that we conducted than are answered. I think if we can address the issue of flow, then the factor of generation of microemboli may become the critical thing that we then need to avoid. And in those circumstances, it should be restudied. It's not easy to give a clear answer.
Yeah, that's good. So we used three-stage cannula because we have to compensate, first of all, the high velocity inside the catheter, and on the other side, the high negative pressure in the MiECT system. So I believe that we need small size of the cannula in order to avoid suction effects to the right atrium. That's my suggestion. Thank you.
Well, we have Cyril as a perfusionist here. What do you think?
Yeah, no, I kind of agree in the sense that I think, we've had a lot more success with three-stage venous cannula than two-stage. I just feel that, a conventional, thinking of this conventionally, trying to maintain a flow of 2.4 liters per minute and not basically taking into consideration anything else for the patient, I think is a mistake. And I think, usually with the MiECT systems, you have a higher, less hemodilution, so you have a higher oxygen carrying capacity, so you can easily get at a deliver the same oxygen at 2 liters or an index of 2 versus an index of 2.4 with conventional. So I think, to Mark's point, it is multifactorial, and I think we really need to address the negative pressures and or venous saturations, etc., and oxygen carrying capacity. Everything has to be put into one. So, the problem is, our cannulas are designed for conventional bypass, and that's what we're actually working with. We have absolutely nothing that's designed for MiECT.
Asio is a perfusionist as well.
Yeah, okay. I think it's not just the venous drainage, it's also as well that we as perfusionists, we have to be cautious with the highest flow. So I think that an important piece of the puzzle will also be the adequate monitoring. If we really try to, we can sometimes, if the surgeon is luxating the heart, is really not needed to create the highest flow. So we also have to look on NIRS, we have to look on saturation of DO2. They take all these parameters into account, because often I see that the perfusionists, they still follow pre-selected flow, and that's all we have to. It's a dynamic process, and we as perfusionists as well, we have also to follow that. We can be for 1 minute, if you have a difficult anastomosis, we can really reduce the flow for 2-3 minutes under the limit that we will not harm the patient with that. I think what we have to learn to understand what happened, and we all know we will try to avoid venous collapsing. We couldn't show that with Doppler is the TCI. We can show that even every venous collapsing, we could detect it in the brain, So we have to avoid that. Absolutely. That will be the goal. And last but not least, we also use the 3-stage.
I'd just like to make a comment. I think you made some very nice comments there. Particularly, increasingly, we've been using NIRS to do exactly that, to sort of monitor the adequacy of perfusion. And I would echo your comments that often, transient flow reductions one can demonstrate are usually relatively well tolerated as far as cerebral oxygen saturations. And conversely, as I mentioned earlier, unrecognized SVC hypertension, if there is poor drainage from the heart, that can impact cerebral perfusion pressure, since it's obviously inflow, mean arterial pressure, minus outflow, which is pressure in the SVC. So it's another source of unrecognized cerebral hypoperfusion.
John, I think one important point is also to check the position of the cannula. We are only checking, so most of our colleagues are only checking the position of the aortic cannula in the aorta, but not the position of the venous cannula in the inferior vena cava. So it should be also standard, to my opinion.
Yeah, I think that's again a very important observation. From the literature, I don't think there's been enough emphasis on the role of unrecognized venous congestion, venous hypertension, and the impact that can have on various organs. As Mark showed, certainly all of the liver-related organs, in the impacted by the IVC. One can demonstrate problems with those. And similarly, in looking at the brain, we can find a similar challenge. So yes, it's and what we've been able to show, particularly in coronary bypass with dislocation of the heart for distal vessels, is that if one if the assistant takes a little bit of time and the surgeon to just readjust using the CVP, you can often demonstrate that just a very slight change in position of the heart can have a profound impact on the efficacy of that venous drainage. So it's a multifactorial issue: the cannula, the position of the heart, and the first step is to be aware that this can be problematic. So I echo your comments. Being aware of the venous cannula and what happens with repositioning the heart, I think, is a real important clinical step that we can all take.
May I make a comment?
Yes.
A statement, as I said at the beginning. I had a question in the statement. I want to unite most of these, not most, all of the clinical presentations we had. We discussed about post-op AF and inflammation. We discussed about glycocalyx integrity. We discussed about coagulation. And of course, myocardial protection, and I would add end organ protection as well. So what is the rationale behind all this? Obviously, what we advocate is microcirculation integrity. So what's the key message for applied physiology when operating on MiECT is the microcirculation preservation. And this includes vasoregulation, microvascular density, microvascular integrity, as Serdar pointed out with glycocalyx, as well as perfusion, microvascular perfusion, which also plays a key role for coagulation as has been demonstrated in the literature. So what I believe is that the more we study microcirculation and MiECT, the more we find that this is the key element behind our clinical results. And when we're discussing, for example, end organ protection, Hans-Georg pointed out that we advocated in our position paper 2016 that it's not just cardioplegia that makes a difference on MiECT, but the perfusion phase, which is half of what is myocardial protection. And reperfusion is just because MiECT offers a better microvascular preservation to the heart in reperfusion phase, especially to the subendocardial layer, as well as to all other end organs. You mentioned the brain and the nerves. I would mention the kidneys, and we can discuss about all end organs that are preserved better with MiECT use. So my statement is, if you want to find out why we have these better results in MiECT, I would say go and study microcirculation, because this is the key point to me. And with this comment, I would ask Professor Punjabi, as the editor-in-chief from Perfusion Journal, to comment both on this and what Rob Baker has implied about results. You know all the results. You are leading the best and the biggest journal on perfusion. So do you think it's sufficient evidence, at least from clinical standpoint, supporting this technology?
Thank you. Yes. I think this has been proved by so the talks that we have seen have referred to manuscripts, publications that have been published in perfusion. So that's very good. And clearly we are seeing, I mean, I think the clinical evidence is definitely there. I think the basic science evidence is also supportive that is there. We just need to probably have a class 1 recommendation of a randomized clinical trial to convince everybody else. I think there are passionate people who don't need convincing, and I think we've started doing a lot more than we ever did. So we are embracing and expanding. Comics is brilliant, and I really am looking forward to the further discussion. But I think that's a step in the right direction, only because to get acknowledged and accepted into any guideline, the level of evidence will need to be a little bit stronger as compared to retrospective or cohort matched studies that we have currently. But clearly evidence is mounting, and it's just a question of time. And I think the group and the society here is quite responsible, because we are the only ones who can do this, will do this, and have the passion to do it. And it's way time to do it. Thanks.
John, is it anything from your side regarding the presentations before we proceed?
No, I think unless there's any further questions from the panel, I think we've had a pretty good discussion to date. And so in the interest of time, I think we should move on, please. Thank you.
Okay, so then we can proceed then to the next session, which is on the industry input to our society. And it's Polychronis and Serdar that will coordinate.
Okay, so thank you very much. So in this session, we are hoping to discuss the implementation of MiECT into clinical practice with our partners on who's working in the industry. And so we prepared some questions that will be on the screen as questions, and probably they all have some kind of presentations. And after those presentations, we just are requesting them to somehow give a comment on each of these topics we prepared for them. So today we have speakers from different companies. So Wim Snooks from Spectrum, Andreas Becker from Terumo, Emiliano Bonetti from Livanova, Carlo Tassi from Eurosat, and Hans Seiler from Califia. And we are going to start with Wim from Spectrum on Medtronic.
Well, thank you, panel. I hope everybody can hear me. First of all, I would like to thank you for the invitation to do this presentation. And secondly, as in the plan was that Mike van Driel would present that, and unfortunately, due to some family circumstances, he had to fly out. So first of all, I would like to wish Mike all the best from, I guess, all the panel and the faculty here. Well, again, thank you very much. And I would like to discuss Medtronic's vision on the innovation and the future of perfusion. There is a very strong pipeline. Is there a... You can see. There's no screen.
May I?
Sure.
Thank you.
So, as we all know, that Medtronic has a very strong pipeline of innovative solutions, and Medtronic likes to commit to the cardiac surgery with some future developments. There is an evolving role of the perfusionist, and there's a lot more involved just by doing bypasses. The role of the perfusionist is expanding into other environments, which is into the intensive care unit and also in the oncology unit. So the systems are getting higher demand, and there should be more functionalities available for the systems. First of all, I'd like to tell you a little bit about the challenges we are facing from the industry. As we all know, new regulations have been implicated from the Medical Device Directive, which is developed into the Medical Device Regulation, which really inhibits developments and also creates a huge impact on the financials of companies, as we need to re-register, or it takes a long time to register new products on the market. It's really driving a significant investment for the recertification, and really we need to update new clinical dossiers, and it's very timely. However, Medtronic is committed to do this and to continue with all the products on the market, and to continue also developing new products. So we continue to develop technologies for the use inside and outside the operating room. Currently, we're also looking at expanding the role for, especially in the cardio extracorporeal life support products. We have access solutions with our cannula, with our catheters, they're dedicated for ECLS, and our ECMO oxygenators, which are designed oxygenators just for the ECLS and ECMO environment. Also, what I'd like to emphasize is that we have now also working with the next generation perfusion systems. The next perfusion systems have a high degree of customization, which helps to drive innovation with especially software platforms. It facilitates team communication and the quality of perfusion. Because it's really important, again, we are developing into new strategies in treating patients, as the previous speakers has discussed. One of the important parts is the data management acquisition. As we all see, data is very important for clinicians. We need to collect that, and we need to be able to work with these data and to make sure that we can drill down the data and come up with the proper data so we can take decisions. It could be on site directly, so we can take clinical decisions, or for studies in the future. For example, also we have the continuous patient monitoring on microemboli. As the previous speaker said, microemboli is a really important factor for the perfusionists to keep a close eye on and to reduce that as much as possible. If we do that, it can save potentially quite a bit of money, and especially with more disposable devices as we have online measurements. The quantum perfusion system is more than a heart-lung machine. It's a next generation heart-lung machine. It offers non-invasive inline monitoring and offers data management. Also, what we can do, just by generating apps for the device, we can have dedicated situations, for example, for mini bypass. Mini bypass is not only software development, but also it relates to the teamwork in a team, the techniques and the technology. The interesting discussion we had previously on the cannula choice, one of the options which is available on the system, you can actually measure venous flow as well as arterial flow. And then you can see and modulate these flows from each other. So you can actually generate a certain view that you're not reducing too much your venous flow, but also not reducing arterial flow. It improves the MiECT with our innovation. We have the biopump, the ventilator system, new level sensors, but also continue with the development of the apps. One of the interesting things is, as Hans-Jörg just said, is about the microplegia. The integrated syringe pumps, which is coming in the next year, will also offer the possibility to do microplegia with this system. We continue the evolution in mini bypass. So it was clinical safety, automation, volume management in the system, and it driving towards the integration of the features. Also, Medtronic is committed for further support for the COMEX study. The next generation ACT HMS. We have now the ACT HMS in 2 devices that will be in 1 device with more assays available in the system to measure the coagulation situation of the patients. A little bit about the heater cooler system, which we are currently launched. Do we really need water in the OR? As we all know, there has been an outbreak of Mycobacteria chimera, and this offers a system which is basically eradicating all the water in the system. It's a glycol-based system. So it reduces the treatment costs, or actually minimizes the infection treatment costs due to water infections. It reduces the cleaning and disinfection costs of the device. And also there is no construction needed for isolating units outside the DOR as indicated by the EX. So the system has actually 3 bays. It has a cold storage charger. There's heat exchangers needs, and it is a total closed system with phase changing material. And it can be done totally in the operating room. So there is no movement of air because of the big ventilators in the system. Medtronic is also heavily investing currently in education and training. As we all know, we have the regional impact courses. We work together with in Thessaloniki, Bern, Braunschweig, Hasselt and Leuven on different topics in cardiopulmonary bypass. Also, we are generating impact courses. All is about the focus on the teamwork with dedicated procedures or alternative strategies for doing bypass. We are also investing in the medicine, in virtual reality or augmented reality situations where we can actually train perfusionists on heart-lung machines, but also on future therapies. So the commitment of Medtronic is that we have a very strong pipeline of innovative solutions, like the perfusion system, the autolock, ablation, next generation cannulas, and we have more EasyLess pipeline products coming up. Thank you very much.
Thank you. So I would like to ask you our prepared questions. Maybe you can give some comments on that. So first, what's your expectations from COMEX study? Do you think it will help you to promote more in MiECT system as a Medtronic company?
The main reason, absolutely. That's also the main reason, as I mentioned, that Medtronic is truly committed to continued sponsorships of the COMEX study, because we see a huge positive feedback coming in from this study, and it will definitely enable us to promote the therapy, as we call it, the mini bypass. Also for us as a company, it's really important to know what are your needs, what are you missing in our product offering, and it's not only from Medtronic, but from all the companies involved in cardiopulmonary bypass. So the continuous conversation with the key opinion leaders, but also with other healthcare professionals, is also paramount for us.
Thank you. And just coming here, so we all accept MiECT as a strategy more than a kind of product. So which new products of you think is beneficial and more important in the MiECT system?
We believe that all the products have a really important role in doing a bypass. As we say, from tip to tip, from cannula to cannula, the oxygenator with an integrated filter is really important to really seriously minimize the circuit and to make the offering really important. The most important part also is the fact that in the quantum system, we have dedicated mini bypass apps. So the system can be totally programmed and will enable the perfusionist to work with the system as safe as they can, with multiple safe and bubble sensors in the system.
And which is your vision for expanding MiECT in cardiac surgical practice? Is it like minimally invasive surgery or optimized ECC, point of care, goal-directed perfusion, or whatever?
It's all these factors. It's multifactorial, and we see more and more interest. The challenges for the surgeons to do more mini bypass and also to do mini surgery, minimal approaches for bypasses. All this we have to adapt and we have to inform each other. Again, we need to know what are your wishes, what can we do to enable you a safe treatment for the patients.
Thank you.
Chris?
Okay, thank you very much. Thank you very much, Wim, for your very, very nice presentation, up to the point, and for the very, very nice discussion that we had. So now I believe that we can proceed to Andreas Becker. He's the representative from Terumo. Hello,
Yes.
Andreas. Nice
Hello.
to meet you online. I mean, for the previous meetings, you've been here in Thessaloniki, so you perfectly know the environment, you perfectly know the atmosphere. So it's the same as, so it's like being here today. So we want to hear your opinion, especially on these questions that we have already discussed. So what can we do in order to promote minimally invasive extracorporeal circulation towards the clinical benefit of the patient, towards producing the clinical evidence that we are eager to find? Thank you.
Yeah, absolutely. Thank you very much for the kind introduction. And it's really a pity that I have not been able to join this year live in Thessaloniki. As always, it's a great honor for me to participate in this session. And I will also try to answer as much as possible of your questions during my presentation. So let me quickly start and go full screen. So let me start my presentation with an update on the MiECT concept from an industry point of view. And it has been mentioned already. If we look at the major clinical practice guidelines, we now see that minimally invasive extracorporeal circulation is listed and recommended. So just this year, the American societies, STS, MiECT, have updated their clinical practice guidelines on patient blood management. And now MiECT is recommended with class 2A. The same is true for the European guidelines of EACTS, EACTA, EBCP from 2019, where MiECT is also already recommended. It's class 2A, so it's not the highest recommendation, but I believe we can consider MiECT already as a standard of care and a method that is superior to conventional CPB. Moreover, if we look at recent market intelligence reports, minimally invasive technology as a whole is considered to be a main driving force in cardiovascular devices in the coming years. So these are very strong indicators for industry to consider a MiECT concept in product development and in our research and also training activities. Just as a reminder, if we look what MiECT is about, it's according to the consensus paper to further improve the biocompatibility of cardiopulmonary bypass components to minimize the adverse effects and improve end organ protection. And I think we all agree that adverse effects related to CPB are mainly the hemodilution and need for blood transfusion, but also systemic inflammatory response and embolic factors like gaseous microemboli. All of these can lead to non-physiological levels of blood parameters and inflammatory mediators and eventually lead to end organ failure. So these adverse effects, this is what we have to address from an industry perspective. What are our current activities to support the MiECT technology? On one side, we are developing new equipment to support MiECT. And here our core competencies in Terumo are certainly on the perfusion disposable side, where we can offer low prime, high performance oxygenators with an excellent GME removal. And another sector where we are very strong is monitoring, be it inline blood gas monitoring, cerebral oximetry, or also goal-directed perfusion monitoring. I would also like to show one additional technology, and this is the first time I'm presenting on this in the scope of a MiECT update meeting. This is endoscopic vein harvesting, which we consider also to be a minimally invasive technology, but mainly related to the surgical intervention, not to the perfusion technology. A second pillar of our activity is certainly training and education. This has been mentioned already. We are currently running a series of live webinars addressing MiECT topics and also hand-on training workshops. So looking at the products that are already available, I mentioned already, we offer low prime, high performance oxygenators. And among the long history of our oxygenator developments, there are two types that are particularly interesting for MiECT perfusion. On one side, this is the FX15, a small adult oxygenator with integrated filter. It's the smallest and most powerful oxygenator in its class and can run up to 5 liters per minute, which I believe is sufficient for most patients undergoing a MiECT perfusion. For users that appreciate to have more safety reserve and more performance reserve, we recently launched a full adult oxygenator with integrated filter, the NX19, which still has a very low priming volume of only 185 milliliters, and it can support up to 8 liters of flow. I think most of you know the CDI monitoring system 550, and many of you are using it. The CDI 550 continuously assesses 12 essential blood parameters, including now oxygen delivery for goal-directed perfusion. It has some unique features like pH, PCO2, and potassium monitoring, as well as basics and bicarbonate. The technology is really proven. There are studies clearly showing that early intervention based on the readings of the CDI improve blood gas management and patient outcome. And as I said already, I wanted to also include the endoscopic vessel harvesting technology in my presentation today, as this is a minimally invasive approach that is beneficial for both the patients and the clinicians. It goes without saying that the cosmetic result for the patient is far better compared to open technology or bridging technology. And there are less wound healing disturbances, excellent graft quality, and it's a method that is also cost effective compared to open technology. And interestingly, this technology is already widely adopted in the United States. It's really standard of care, while adoption in Europe is still very limited. And we are at the beginning to establish this technology, while with the MiECT circuits, the minimally invasive perfusion circuits, it's the opposite, right? They are very broadly used in Europe, but only starting to develop in the United States. Just to address our second pillar, learning and education, MiECT clearly requires a change of concept, and it is a team approach. So we believe education is essential to overcome the learning curve. That's why we offer vet lab training sessions, also using simulation. We have a big clinical support team with experienced perfusionists and physician assistants, and an extensive online learning program to promote MiECT technology. What are our future plans? Certainly, we will keep developing equipment, having the MiECT principles in mind, and this will be across all product lines. Obviously, focus will be on oxygenators and CPP circuit components, but also on the monitoring segment and other minimally invasive techniques like the vein harvesting system I showed. And certainly we will also continue our education and training activities. We are also supporting perfusionist education directly at perfusion schools. And we are now using more and more digital media like our webinar series, but also hands-on training on relevant equipment and procedures. So this concludes my presentation of today, and I will be happy to take any questions. Thank you very much.
Okay, Dr. Becker, thank you very, very much for your presentation. So just to summarize, what about the COMIC trials? Do you consider that the results could change your product strategy, let's say on that, on promoting MiECT? What's your opinion?
Yeah, absolutely. As I said, I believe there is already a whole lot of evidence related to MiECT, and we see it's already in the guidelines and it has a recommendation. It's not the highest recommendation, and if the COMIC trial, which will certainly be one of the largest, if not the largest trial, can improve the situation and move it from class 2A to class 1, I think this will give an additional push to the technology, and this is our hope now, yes, that the COMIC trial can contribute to this.
And what about the multidisciplinary strategy? Do you adopt the principal surgeon, anesthesiologist, and perfusionist working as a team and applying physiology together? Do you consider somebody to be more significant than the other?
I would not consider one more significant than the other. I think it requires a real team approach. And that's what we see also in centers using MiECT technology, that the team can only be successful if every specialty contributes and buys into the concept. So this is essential. Historically, I think our focus has always been more on the perfusionist side. Our main technology is on extracorporeal perfusion. But recently, we have started to also develop new products for surgeons, be it minimally invasive technology, also like the vein harvesting system. And this segment is currently growing in our organization as well. So we really support the team approach, that's for sure.
And which products from your pipeline used in MiECT would you consider as an asset for this technology? Is the Capiox oxygenator, let's say, the stronger asset of Terumo?
Yes, this is certainly true. And we have changed our strategy a little bit, I would say. In the previous years, we tried to come up with a kind of standard mini circuit with a fixed design. But what we see in daily practice is that many hospitals modify their circuits anyway. And also from the consensus paper, we see already there are 4 different types of MiECT. So today, we think it's a better idea to contribute with high performance components and leave it up to the customer's choice to assemble a customized circuit that best meets the hospital requirements and local requirements. And on top of the oxygenators, I still believe that monitoring should be also an important part of MiECT technology. This is not only blood gas monitoring, but also cerebral monitoring like NIRS technology that should play a key role in the technology. And this is also one segment that we are certainly supporting.
Yes, and finally, how do you think that we can expand MiECT in clinical practice? How can it penetrate more, especially outside Europe?
Yes, and I think this is really the training and development part where we need to educate young surgeons, young perfusionists and anesthesiologists, inform them about the technology, present the clinical evidence that is available, and also train on the technology. This will be very important. On top, I believe what you are doing with the society to have regular symposia, congresses, update meetings. I mean, this is certainly very helpful to spread the knowledge and to promote the technology.
Okay, thank you.
Can I also ask a question? Yeah. So Andreas, hi.
Hi, Sada.
So, for example, we are using our customized mini system for MiECT in our hospital. So we sometimes use Terumo products and also FX15 for many of the patients so effectively. And also we just started using endoscopic vein harvesting. So last time we have a mid-cap patient with endoscopic vein harvesting, minimally invasive extracorporeal circulation. So the patient has total like less than 15 minutes, 15 centimeters of incision, 5 for the mid cap and maybe 5 or 8 for the saphenous vein. So it's a complete success. So we were very happy and pleased to have such a patient using every available technology. And so Terumo is one of the earliest companies that just produced dedicated mini systems, you know. So it was Procter and it was going everywhere inside the country to start that. So considering all those new technologies you're using, like monitorization, vein harvesting or whatever, and as far as I see, most people were using customized systems, but now they turn out to search for already available systems to use as a MiECT system. Will Terumo consider to produce again a mini system as a package for customers?
Yes, Sada. Well, first of all, I'm very pleased to hear about your success in using our technology and especially the vein harvesting. I agree. This is a very useful, minimally invasive technology, and it's now starting to grow also in Europe, not only in the US. Regarding your question on mini circuits, we still produce our fixed design standard mini circuit, which we call RockSafe. And the picture I showed with the FX15 was actually the configuration we are using with a venous bubble trap and a centrifugal pump. So this is still available, but on top of that, we are also prepared to customize the system and to produce a dedicated system based on specifications provided by our customers. So we are flexible in whatever the customer likes to have.
Thank you.
If I could make it just a very brief comment, I'd like to thank you, Andreas, for that presentation. And I'd like to just refer back to some of the previous comments that have been made. For approximately the last 15 years, we've been doing endoscopic vein harvesting in our institution. And it is quite remarkable from a patient standpoint how much the lack of a big scar has impacted their early mobilization and other aspects. Yet, paradoxically, as we've discussed before, in North America generally, and certainly in our center, we've still been reluctant, for reasons that I'm still struggling with, to fully adopt MiECT technologies. So I think as we keep focusing on these issues, minimizing the trauma to the patient, the better we can preserve these physiologic mechanisms and minimize just even the pain and impact of such things as long incisions, whether it's in the chest or in the leg, as well as incorporating a more physiologic bypass approach are very, very, very important. So yeah, thanks very much for your comments.
Thank you very much.
Mark Bennett would like to add a short comment.
I'm absolutely delighted that in the last year and a half, both of the industry that have presented so far have clearly laid out their simulation and training, because this surely forms perhaps the greatest opportunity to go over the tipping point that Rob Baker and Prakash Punjabi referred to. There is already level 1 evidence for so many outcomes that are of importance to surgeons, and just wondering how you go over that tipping point where is really the question. It's the elephant in the room, really, isn't it? Currently, some centers will send some teams to be simulation trained, and really where we need to arrive at is where all centers send all teams. and then you will overcome the hurdles to adopt what everyone will accept are the clinical outcomes that they would desire for their patients.
So we continue with Emiliano Bonetti from Livanovo.
Hello.
Hi, Emiliano.
Hi, good evening. Good evening, Policarnis. Good evening, Dr. Sadar. It's a pleasure from my side from being here on behalf of Livanova, and I would like to thank you really very much for this kind invitation, first of all. Then, as the other, I have a few slides that I would like to share before going into the live of the discussion, and I hope that some of the points that we already touched are going also to be covered by my presentation. Just 1 second that I'm going to put it on presentation mode. Here we go. So for what concerns the minimally invasive extracorporeal technology, here with Livanova, we would like to share a little bit a panel of solutions that we do have into our portfolio that have been recently brought to the market in order to facilitate the adoption of this approach. And just to reiterate some of the messages that have already been delivered, we really think that it's a kind of team approach. And we as an industry really have to commit and to bring solutions that are facilitating the adoption of this technology. And we started from what concerned the heart-lung machine, the heart-lung equipment. And as already presented in this forum a year ago, I would like to mention that the S5 hybrid, it's our solution for what concern the reduction in the footprint. And this is really something that has been widely adopted in the last 12 months, even above, let's say, our expectation, to really decrease and reduce the distance between the perfusionist and the patient. And this was able because we have been capable to combine actually the flexible and modular configuration and the technology of the S5 in a smallest footprint, because we know that reduction and minimization is one of the key elements, and also on the capital equipment, on the hardware. And that's why with the S5 hybrid, we have been able to reduce by 27% the footprint versus a regular S5. But it's not only about the equipment, it's also about the, let's say, the disposable. And for what concerns the disposable, we completed our family of Inspire oxygenator with the Inspire 7. And this is the last piece of the puzzle that we added into our full family of oxygenator, that is Inspire. Up to now, we have treated successfully more than 2 million patients with this oxygenator. And we completed the family with a 7 liter per minute oxygenator that is capable to reduce the blood path resistance. And we've been able to reduce the transmembrane pressure across the oxygenator by increasing the void fraction of 10%. And this Inspire 7 is present and available in all the configurations that are more suitable for the minimally invasive approach. And here I'm talking about the closed system, so with the solid integration with our SVR, soft venous reservoir, 1 liter and 200 ml. And then it's also available in the configuration with the Inspire Mini. So in the more, I would say, based on the consensus paper on the type 2, type 3 configuration, and then also into our type 4 configuration, which is the hybrid, in which we do have this kind of open reservoir on a standby that is giving this back of the mind security to the perfusionist, to the team, to migrate into a regular extracorporeal circulation system in case of need, easily just by removing a couple of clamps. But we also think that monitoring has a key role, and that's why in 2021 we brought on the market the MiECT. And MiECT is an inline blood gas monitoring system that is providing accurate and reliable measuring, live, continuous, on the venous saturation, on the hematocrit, on the arterial temperature, as well on the PO2 of the arterial side. But key advantage of this device is that it's ready to go, meaning that it's immediately available to be used. You do not have to go under calibration with this device, and it's sufficient that you switch it on and it provides all the parameters in an accurate and reliable way. Of course, we've been the first one to spread that to market, the goal-directed perfusion, and this is completely compatible and completely integrated into our offer in measuring all these parameters into our goal-directed perfusion solution. But it's not only about monitoring and measurement, it's also about cannulation. One thing that I would really like to mention is that also peripheral cannulation has a key role. And we, and Professor Gunnaydin knows it very well, we have been also adding into our portfolio the biflow cannula. And the biflow cannula is a femoral arterial cannula that is designed to the peripheral approach and to mitigate one of the main clinical challenges that this kind of cannulation has, which is the distal limb perfusion. And we know that maybe in traditional extracorporeal circulation below 6 hours, this is maybe less impactful, but when we go above and beyond, and eventually also in ECMO cases, we know that this is one of the most frequent complications. And our solution is providing an arterial femoral cannula with a distal lumen of 6 French that is capable to divert approximately 7% of the mainstream flow downwards to the distal limb, to provide in a very easy and agile way to perfuse also the distal part of the leg. We have 2 versions of this device for extracorporeal circulation, for minimal invasive in particular approach, and also for ECMO setting with the validation up to 29 days. And with different, let's say, fixation ports that are making the positioning of this cannula more suitable for a long-term usage. I also would like to mention another part of our portfolio, which is the Protect Duo, which is a dual lumen cannula. And this dual lumen cannula is a very minimal invasive way to unload the right ventricle. We know that in some cases, also after the extracorporeal circulation, we might have the need to provide a less invasive and percutaneous approach to download the right ventricle. And here in the Protect Duo, we do have the unique feature of having the reinfusion of the blood directly into the pulmonary artery to improve significantly the recirculation problem that it's known to happen when we're talking about dual lumen cannula. So you see that here in LivaNova, we do have really an approach that is covering all the aspects of our of the extracorporeal circulation, and it's not only one single device, but we really believe that the only way to make extracorporeal circulation more towards the minimal invasive approach is really to facilitate the mental burden that many people do have, and facilitates also the learning curve.
Thank you very much, Emiliano. I also want to ask you questions. So what about, what do you think about the possible support of the MiECT trial and the results? What's your expectation as a company?
Well, of course, we are in any case investing quite a lot in the minimization and let's say in the next generation of our devices for what concerns the next generation HLN, the next generation oxygenator, already in that direction. And we really believe that the MiECT trial can be another milestone to provide supporting evidence in order to facilitate the adoption. Let's say that we will, in any case, go ahead in developing and lay out a panel of solutions that will facilitate, from a perfusionist standpoint and from a surgical standpoint, the adoption of the approach, of the method. And we really hope that the COMICS trial will also support, by the clinical evidence, this two angles, two-side way of going in the same directions, from the industry and from the clinical side.
So we also have experience with some of your new products in our clinic, including Biflow cannula that we use in most of the minimally invasive surgery. And we also tried the Inspire Mini Hybrid. So what is the feedback for this Inspire Mini Hybrid in the market? Did you start selling them, or what's the feedback?
Yeah, we do. And as my colleague in the room, we also believe that customization is key. And based on our experience, we evolved, let's say, from providing fixed and standard solution to provide also customized solution, because we really think that the hybrid, with all the customization in terms of length, sizes, and so on, but it's really something that is giving the sense of safety to the team that maybe a more extreme type 1, type 2 circuit is not giving. The possibility to have, just by lifting these two clamps and going back into a traditional open heart circuit with the reservoir that is the normal one, it's something that is really facilitating a lot the adoption, at least in the learning phase, in the first cases.
Thank you. So you have many products also related to MiECT systems. Some, as I've told you, we used like this Inspire Mini plus Bicapta and plus Biflow. So which do you think, and which is your vision in expanding MiECT in cardiac surgical practice with all those products?
Well, we really think that also when we're, let's say, having heart valve into our portfolio at the time of Perceval, that minimal invasive is above and beyond the minimal incision. And it really has to consider tip to tip, I mean, the full approach. That's why we really consider that when we talk about minimal invasive, first, number one, it has to be a team approach. So the surgeon, the cardiac anesthesiologist, and the perfusionist has to be on the same page. They have to go in the right direction, and they need to be accompanied in a way or another from evolving to a traditional open reservoir, hard shell reservoir, to a more minimal invasive circuit. And so we need to invest, as all the other colleagues mentioned, on training, on having centers of excellence that can provide witness and help new adopters to go into this direction. And of course, having solutions that are not that extreme, like in the early 2000s, by having something that is more, let's say, comfortable, like the hybrid configuration, is something that to me and to our experience is facilitating the expansion of this approach to a broader audience.
Thank you.
You're welcome.
So thank you, Emiliano. Thank you, Mr. Bonetti, for your very, very nice contribution to this to the third MiECT update meeting. And so we can move to another Italian. I think it's Carlo Alberto Tassi from Eurosets. Hello,
Good
nice
evening.
to meet you again.
My pleasure. Good evening,
Yes,
everybody.
you've been-
Thanks again for the invitation. It is always a pleasure for us as Euroseta to support the MiECT Society. By the way, we had a very nice discussion in the previous sessions, and just let me allow to transfer my thoughts, that I really believe that the MiECT is more a strategy than a therapy. Reason why all the actors that are present in the theater are so key, so important: cardiac surgeon, anesthesiologist, perfusionist, craft nurses, etc. And even the companies, because we can offer, everybody can offer a state-of-the-art product that can really contribute to have a minimal invasive strategy in order to have a better patient outcomes. So I would now try to share my presentation. Just to let you know that in the previous meeting, I hope you see the slides. In the previous meeting, I was presenting to you our new solution in terms of oxygenator module for the minimal invasive extracorporeal circulation. And after the previous meeting, we were, let's say, diverting our R&D people in a brand new solution for a venous reservoir. Reason why now I'm presenting to you a brand new sub-venous reservoir that is a very nice tool that it was not available 1 year ago. This is a real demonstration that we do as a company really believe in the minimally invasive extracorporeal circulation. The bag is called SDR, that is quite common, soft venous reservoir 2000, means the capacity is 2 liters per minute. It's really flexible, safe, and simple solution for closed system. It features a unique volume range to address volume changes or even different clinical practices. It has the lowest minimum volume in the market when it works up to 5 liters per minute, just 250 milliliters, and the highest maximum volume in terms of capacity, 2 liters. And it is provided with a dedicated squeezer in order to better management the volume, especially during the weaning phase. One of the main points focusing the R&D during the developing phase was to work on the gas microemboli capability handling of the bag. Reason why we introduced several technical characteristics, not only the filter, but especially the fluid dynamics that will push eventual gas microemboli coming from the surgical field directly through the purging line. And the results are pretty impressive, the preliminary results. In fact, the gas microemboli removal is 99.95% at the maximum flow, 8 liters per minute, and 99.99% at 2 liters per minute. Of course, the circuit and the bag is fully coated with phosphoryl. It could come pre-assembled, so all together with a single-use plate bag reconnected with the oxygenator. And here you can see an easy fluid dynamics where the flow is directly conveyed to the upper part where there are 2 purging lines. In such a way, eventual gas microemboli that are coming are evaluated in a very easy way. This is just a preliminary video that we did. It was one of the first clinical cases, and you can see during the priming procedure that the hair that is on the top of the bag can be extremely simply purged through the 2 purging lines. Okay, this is a typical, let's say, MiECT Type 3 configuration, including in this case our brand new sub-venous reservoir 2000, so 2 liters as a capacity, and our new oxygenator with integrated arterial filter. This was a winning phase at 50% of the target flow. As you can see that the bag managed the volume even in this condition. Okay, so thanks a lot, and come back to the live session here.
Thank you very much, Mr. Tassi, for the excellent presentation. I believe that it's new from what we've seen the last 3 years. So yes, you're now part of the MiECT group and part of the COMICS trial, I believe, because the Antea Hospital in Bari is actually contributing. They're recruiting cases for the COMICS study. So what do you think? So what are you expecting from the results? What are you expecting from COMICS trial?
This is a very good question. So we do believe, I think that I already demonstrate with the new product that we are launching every year on this MiECT approach, MiECT strategy, and even on the tough, let me say, and deep focus of the R&D developing new products as this new sub-venous reservoir. I do believe in the result because the future of cardiac surgery for sure will be mainly driven by the minimally invasive procedure. But what is extremely important in order to obtain a good result is try to reduce, and this is something up to you, let's say up to the center that are attending the study, to reduce what we call it the procedure bias, due to the fact that the techniques, the methods adopted by several different hospitals in the material and method sometimes are slightly different. So we should try to reduce as much as possible the procedure bias in order to obtain effective and efficient result to sustain this strategy or therapy, which we really believe.
Okay, thank you. And what about the strategy? Which discipline do you consider the most important, the surgeon, the anesthesiologist, or the perfusionist?
As I said before, the result never comes from the single people, always comes from a team. So every actor present in the theater has the same importance: surgeon, anesthesiologist, scalp nurse, perfusionist, and even the company that can provide the devices that you are currently and daily using. So I really believe that is a multifactorial strategy. So all the players in the OR are important.
And also you stressed that from your pipeline, I understood completely that the soft bag reservoir, it's an asset and it's something that Eurosets would like to promote. And,
exactly. It was honestly...
Yes.
Sorry, it was honestly developed after the previous MiECT meeting, because we had something that was not really in line with our, let's say, expectation, and we developed something new as an asset, including an innovative fluid dynamics developed with some university here around, and we will promote for sure these techniques around Europe, etc. The preliminary results are really interesting, exciting, so it works very, very nice, and we will push for this. Besides, on the bag, we have, that is a brand new venous reservoir, we have the oxygenators, that is new because it was recently launched with an integrated arterial filter, small primates, small contact surface area, etc., and even the monitoring system that is called landing, that is a metabolic patient monitoring, able to understand in a real time if the patient is in aerobic or anaerobic condition, helping the perfusionist and surgeons, anesthesiologists, or the physician to adjust, let's say, the parameter to maintain as long as possible the patient in aerobic condition during the entire corporal circulation, preventing, the acute kidney injury and potential multi-organ failure.
And how do you expect to expand, let's say, what's your strategy in expanding MiECT technology? Increase penetration of practice.
Yes. For sure, we believe in your society at first, because I really consider that you are doing a very nice job trying to expand this strategy that can even become a therapy. We are investing as well in education with our internal education center, and all our, let me say, representatives are really stressing day by day all the final users just to try to initiate to adopt this mini extracorporeal technology.
Okay, thank you very much for your continued support in MiECT activities.
I also want to ask, hi Carlo, how are you? I also want to ask you a question. So you're talking about SVR 2000 and a new oxygenation system. So most of the MiECT systems are heart-lung machine specific. So this time, when you produce soft shell reservoir plus the new oxygenator, that can be used in any type of heart-lung machine, right?
Yes, correct. It's not a captive system. Obviously, if the user has a centrifugal pump, the only captive component is the centrifugal pump that depends on the heart-like machine that you can use. But of course, the brand new venous reservoir and the new oxygenator with integrated arterial filter can be used with any type of hardware configuration and any type of heart-like machine.
Thank you.
Thanks to you.
Okay, thank you very much. So we are going for the last presenter. Hans Seiler from Califia. As you know, Califia is a very good simulation system. So Hans probably is very important in this sense for the education and training of the people who wants to use MiECT. So hi, Hans, it's your turn.
Thank you, Professor Gunadin. I was a little bit blindsided when Bolly Kronos asked me a couple of minutes ago to give an update on the situation and simulation here. So this is also why I'm having no slides. And so I'm very sorry you have to watch my face all the time now. Simulation, we did it 3 years ago together with Apostolos in Kerkrade in the EECK. What we did was a little bit routine bypass with a mini bypass system. We did a little bit troubleshooting, and this was the way how we did. And then something happened. The pandemic came into our world, and this little bastard of virus has changed a lot. Also in our field of the simulation, if I would have asked someone 2 years ago, we have here a complex situation. It's a physical training. We do it in a wet lab, and please convert this into virtual reality. He would say, ooh, costs a lot of money and takes 2 years. Impossible that someone was able to manage this within 4 weeks, simply because we could not travel anymore. There were no wet labs, and so the situation was under a kind of pressure. However, I have to confess, the main topic and the top priority during the last nearly 2 years was not mini bypass. It was, of course, the hype, and the hype is ECMO. However, there are still some let's say, synergy effects with the mini bypass. Marco Ranucci said once, mini bypass is intraoperative ECMO, and I think he's right. So what we've done so far in the last, let's say, 1.5 years, we have added another feature to the simulation system, and this is Califia Lung. This is a lung simulator which can be used even standalone for ventilation training or training of mechanical ventilation. However, it makes only sense if we use it in the context in the network or in the closed network together with the perfusion. And I made already some experiments to use a lung simulator together with a feature mini bypass, and we were trying to simulate situations where we have a patient which is still on beating heart, and mini bypass is only supportive to these. As you know, we have already these feature mini bypass into the simulation software. However, it was not further developed over the last 1.5 years simply because of the ECMO hype. There are some features which are helpful for the future, like the fluid panel, so we can easily play with different voluminas. What is also established is the complete GDP parameter, so we can even predict the patient outcome on the simulator. And of course, due to the fact that we are now in a virtual world, Apostolos, it doesn't look like any, as you know it, so it's completely different. We have a completely new graphic user interface. So we are living in a 3D world, and we are living in a virtual world. And for these design of this new graphic user interface, we have hired one of the top stars from the gaming industry from the United States, and he's doing a really fantastic job. If you would ask me how I would perform a training for mini bypass virtual reality, no, never. This is Mickey Mouse movie, and this is not what we want to do. We are going into the direction of augmented reality and even mixed reality. Mixed reality means that we can control devices via the mouse click from over a long distance, over countries, over continents. And so these are the tools what we are planning for simulation and training. I'm working close together now with a company in Munich. This is called V-Frame. So we are displaying all these environment onto huge, gigantic, not gigantic, it's only 95-inch monitors, completely interactive. And we can use this also interactive for training sessions like this here. And since about 2 weeks, my wife thinks I'm totally crazy because I'm walking through the house with these HoloLens 2. I'm trying to get my experience and try to bring in some some new features, and we have already, for these training purposes, already added some different modules, and of course the simulation software will be updated on a frequent basis. We have different oxygenators, we have different devices like heart-lung machines. I can push out a heart-lung machine and bring in a new one simply with 2 mouse clicks, and also for different pumps. Yeah, this is what's in the pipeline, and I definitely think that mini bypass will climb up a little bit in the priority list of biomed simulation, and let's see what's coming next. Thanks.
Thank you very much. So do you have any specific program or simulation for MiECT?
Well, in the year 2014, when we had this kickoff meeting here in Thessaloniki in the Congress Hall, for this purpose, we developed the first, let's say, basic software for mini bypass. It means simply the combination of ECMO and CPB into one module in terms of the algorithms. However, what we have learned now is that we have expanded the algorithms, and we had someone who did a really, really fantastic job. And unfortunately, he passed away 3 weeks ago. You know, I'm talking about Jeff Riley.
Yeah.
Yeah, so, but anyway, we can on this, we can build up the next generation of simulation, and I'm sure it will come soon.
So how do you think the adaptation of the perfusion students to this type of MiECT simulation, is it difficult for them, or?
I don't think so. I think we are facing a kind of change maybe in the future, or at least I hope so. If you look at the guidelines from Euro also for the training, it says 50% of these trainings should be based on simulation. And I think it will be the same in the perfusion training, or even in the continuous training of perfusionists. If we compare it with the airline industry, everyone is forced to attend a simulation training once every half year. And I think in about 5 years, we will have the same situation in perfusion as well.
So I know Khalifa has a very good market share in US. How about in Europe? Is simulation becoming more and more popular in Europe, or it's already been popular?
It is definitely in Europe picking up, but even more, it's really booming in let's say in the Far East and in the Middle East.
Thank you very much. So thank you. So we have a couple of minutes, and I want to give the podium to Kyriakos.
Thank you, Siddharth. So I'm very happy that industry from the first beginning was a partner to this society, and I want to thank everyone for the ongoing support. And as you have appreciated, we consider all these managers and people from the industry our partners to evolve this technology and go on. So on these grounds, I want to emphasize three issues. One has been already pointed out here. This is a picture actually taken yesterday from our OR when Wim Snoeks was there, and this is the modular system with the new model from Medtronic. So since we said that MiECT is an established technique, there is no concern from what you have heard. Everyone admits that there is no more issue regarding feasibility, safety. So what is then been left is results. So if it's a matter of superiority from the results, what Rob Baker pointed out is a perfusion's option. So for me is why should a perfusionist to leave his comfort of the conventional CPB and learn this thing here, which to me is not that mini as supposed to be sold from a company. So as from the first beginning said, in this society, this is a minimal invasive, not mini. So a question to Wim and then to Apostolos, our chief perfusionist. So Wim, is it easy for a company like Medtronic, who is trying to support this very, very nice contemporary digitalized module as the Quantum, to have this mini or minimal invasive circuit as a standard setup? How would you promote that?
First of all, I wouldn't say it's easy or uneasy. The interesting part of this whole system is that you can have this system start as a conventional system. And just because it's modular, you can move pumps around and adapt to evolving therapies. For example, a perfusionist who wants to evolve from a mini to a MIDI to from a regular system, it's very easy to do this system because it's modular. So as soon as they get the hang of it, to understand the system, which is part of a training program, they can adapt to new technologies. And it's very easy to have the system adapt. And we found this, as soon as there's a comfort factor with the system, to go to the next level, it's pretty easy. It's the total adaptation of a system. But again, as you rightly said, it's a whole team thing. The perfusionist can be very excited and can adapt the system to mini bypass. But if the surgeon feels uncomfortable, or the anesthetist or the whole team, then it falls and goes with an adaptation by the whole system, by the whole team.
So on this ground, I would ask Apostolos, who is most of the time a bit stressed with all this technology that is in his shoulders. What's the top benefit that the perfusionist can offer to the patient when he's utilizing this complex and demanding circuits and systems?
So I strongly believe that it's not only the circuit that make the difference, but if you want to enhance your results, then you have to perform a strategy, the MiECT strategy. And that includes not only the system, but all the peripherals. As you can see in this device, we have a monitor for monitoring all the metabolic parameters, like DO2, VCO2, and it is well known the relationship between these two parameters in order to avoid to go in the anaerobic metabolism. So yesterday we challenged with this device. We perform two cases, aortic valve and replacement of ascending aorta. And I was very impressed from this device. It's completely safe. We had some incidents of massive air, but the device responds well, and I'm very happy with this device.
So from what I realized from your saying is that the industry really assists what we advocate, and we are really thankful for this. I would also go for a provocative comment. It seems that also we helped the industry on the other way. It's already here when Carlo Alberto Tassi from Euroset said that they have developed this soft shell due to MiECT's initiative, and also Hans Seiler admitted that after being here in the first meeting in 2014 from MiECT, they have started shifting towards developing Califia software for mini bypass. And this is something that it seems to be bi-directional, I mean, going side by side to advanced patient care. And last but not least, it was presented by Andreas Becker that joint guidelines from MiECT, CIACTA, and BCP 2019 went to the United States, STS, SCA, AMSECT, and SABPB about patient blood management, as I have discussed with Rob Baker 2 years after, 2021. It seems that the states are following a couple of years what the Europeans are doing because they believe they should be very well based before introducing that. But what gives me the optimism about this is that industry is introducing these guidelines before. And so we need you to force the technology towards implementing them in clinical practice and offer products as we discuss and be with us continuously so as we ultimately offer the best treatment for the patient, which as a group, we believe this is the minimal invasive extracorporeal circulation. However, as Apostolos pointed out, this is a strategy. So to become therapy, you need everything on board. And that's why we're doing these sessions. So with this comment, I think we should go on because we are late. Just a short announcement that we have more than 200 people, John and Cyril, the former and the current president of MiECT, that are, keep attending, and more than 5,200 people that have viewed the meeting. But these 200 people that are all this time with us is something significant because they are, live viewers.
Just a very brief comment, Kyriakos.
Yes.
Yeah, I want to echo your comments. I think the real brilliance, if I can use that word, of this organization is the fact that it is multidisciplinary and directly involves industry. And we had similar experience with our Key West meeting years ago because it's this interaction that allows one to view issues from different perspectives. And as you said, industry is very responsive to issues that are raised, and clinicians are very responsive to considerations that they may not have had previously. And so, once again, a multidisciplinary international society such as this really is a very important means by which we can really move the ball forward. And I just really want to echo those sorts of thoughts. And I think, again, the discussion today is sort of an illustration of that fact.
Okay, so we are going on for our next and last session for today, which is the position paper that has been published in 2016, MiECT, and after 5 years, we think as a society that we should go for a focused update. Well, what I want to emphasize is that MiECT made order from chaos when we took over and tried to define what is a MiECT. So we had a unanimous definition of what should be considered as MiECT onwards. So the last 5-6 years, people that are reporting on MiECT, they imply the same circuit, which is now categorized into 4 types, as we all know. And also, we described that this is a technique that unites disciplines, as the former president, Professor Merkin, said just before. Now, after these 5-6 years, from 2015 onwards, that MiECT is introduced all this in the literature, we have some significant input from research and clinical trials that we try to summarize so as we refresh our statements and see if they are still valid or if we have any new that has to be added. On this ground, MiECT's board of directors gave the coordination to our secretary, Professor Andonitsis, who has done a very nice overview with our cardiologist, Kostas Theodoropoulos. They have made an extensive research in the literature, summarized the results, and we formed the MiECT's experts group from the people that you will see. all these people took our provisional draft, the draft of our provisional statements, and what we would do now is we will follow the Delphi process, as Polychronis will point out. So as we will vote about the statements that have been distributed to the experts panel, and after that we will be able to have all the rest of the authors to endorse this manuscript, and then we will be published to our journal, which is the official journal. It is Perfusion, and Professor Pujabi already endorsed it, and it will be published there. So I will give John Merkin, who was last time our official reviewer before being published, to coordinate with Polychronis on the presentation of this focused update position paper. So, John.
Good. Well, thank you very much. And I think if Polychronis is there online, it'd be very important to have him sort of guide us through this session. I think everyone, as mentioned, has had the opportunity of reviewing these, having a look at them. And I guess the best plan is to go through these recommendations one at a time. So, Polychronis, if you would like to proceed, thank you.
Okay, thank you, John. So we can we have a presentation. We have a presentation that we can. So what we've actually did is that we based our focused update on the basis of the position paper that was done back in 2016. It was published in 2016. It was based on an expert consensus that we did in December 2014. What is the main difference between the pre-2016 and post-2016 era is that we now, so this is the group of experts, that we now have this paper in 2016, where the multidisciplinary effort of cardiac surgeons, of cardiac anesthesiologists, and of cardiac perfusionists toward defining minimally invasive extracorporeal circulation. And what happened since then? So we can see that there is a multidisciplinary effort to produce guidelines, like the 2017 MiECT guidelines that talk about minimally invasive extracorporeal circulation, MiECT. We have the 2019 MiECT and DBCP guidelines that actually discuss about MiECT as well, giving a 2A class and level of evidence B recommendation for reducing blood loss and need for transfusion, and as a better circuit rather than the conventional cardiopulmonary bypass. And we also have the recent STS, SCA, AMSECT, and SABM guidelines that were published recently, mentioning that MiECT is also a blood conservation strategy. So what actually did the 2016 paper, position paper, was that it defined an error. It defined a cutting point between the pre-position paper era, that was all this terminology of miniaturized extracorporeal circulation, mini CPB, miniaturized perfusion circuit, minimized bypass, and the post-2016 era that has a minimally invasive extracorporeal circulation defined closely so that we can follow the results since then. That's why it is very, very important to produce a work that is actually presenting the new evidence that is that emerged on the field, with the view and with the knowledge that we are discussing about the same thing, that is minimally invasive, that is MiECT, and we are comparing strategies using a certain terminology and a certain strategy. Of course, the classification has been unanimously adopted, and now we can discuss about the four types: type 1, type 2, type 3, and type 4. This is a standard. And for producing this paper, we have actually adopted the modified, the MiECT's modified Delphi technique. So we have discussed with the expert panel, we have produced a paper, we have produced statements based on the best evidence that we and Konstantinos Odoropoulos and me have produced. And then we will according to the comments that we will do today and the results of the vote, we will reshape, let's say, the manuscript to reach a final format, and then this will be given to the other experts to be validated, and then will be published. So the first statement that we used as an extra statement is that use of modular type 4 MiECT eliminates any safety concern regarding air handling and volume management and ensures technical feasibility of all cardiac surgical procedures. And this comes from evidence from retrospective analysis that we have actually discussed about today, that the technical success rate is consistently 100% and that no related adverse event have been observed. So I think that this is a very, very important statement, and I understand that we all agree about. So, from the panel.
Is anyone who disagree about this statement? This is the question from the expert panel.
Okay. So I think that from the whole procedure becomes evident that use of a modular MiECT eliminates any safety concern regarding air handling and volume management and ensures technical feasibility of all cardiac surgical procedures. The other statement that has been added to the previous position paper is that integration of MiECT advances minimal invasive cardiac surgery by combining reduced surgical trauma with minimal body's physiology derangement. And this is the result of multiple randomized studies from Baumbach, as we see in 2016, and large retrospective analysis and propensity score matching studies, as did Beretta in 2000, as published by Beretta in 2020, showing that minimal invasive cardiac surgery with minimal invasive extracorporeal circulation result in reduced surgical trauma and preservation of body's physiology derangement. I would like to add something very, very important, that this statement has been reviewed by Bob Chiai, and who actually said that he absolutely agrees with this statement. Bob Chiai is the president of the ISMICS, and he absolutely agrees with this statement, and this is something very, very important that needs to be mentioned. These statements do not have a class of recommendation and the level of evidence. These are statements of the society based on the available results that we have. So I hope that everyone agrees to this statement.
Yes.
Okay. So we can discuss about another statement on coagulation management. We have heard about an update on the coagulation management with minimal invasive extracorporeal circulation by Helena Argyriadou. So the previous statement, the statement that was presented in the 2016 paper, said that within a MiECT strategy, less thrombin generation may permit reduced heparin dose targeted to shorter ACT times, and this had a class of recommendation 2B, level of evidence B. And when such a strategy is followed, individual heparin dose should be determined using heparin dose response monitoring systems. During the last 6 years, we have evidence coming of randomized trials like the one published by the Danish group, by Modrau, in the European Journal of Cardiothoracic Surgery, which show with evidence, as Rob said, with a higher class evidence that there is reduced thrombin generation in during minimal invasive extracorporeal circulation. And also we have the randomized study published by Adrian Bauer, comparing an ACT strategy of 300 versus an ACT strategy of 450, which showed that a low anticoagulation protocol is safe and effective with minimal invasive extracorporeal circulation. Reviewing this paper, Ashraf asked the question whether there is clinical implication of the last statement. Adrian has sent evidence that is not published yet, that he is going to announce today in MiECT, and this is based on his thesis that there is evidence of reduced blood loss following this strategy. So there is also clinical implication with this strategy. My question is, when we were discussing in 2014, we said that this is a class 2B recommendation, and I think that in the light of the new evidence, we can keep the level of evidence B, but we can say that less thrombin generation is a class 2A recommendation with minimal invasive extracorporeal circulation based on the results of a randomized study by Maud Rau and of the randomized study by Adrian Bauer, and foreseeing the results that will be published in the future.
Yeah, my only comment was, do we think that there is enough evidence of benefit in order to make such a recommendation? Because that it's possible, I think we can all agree that it's possible. But should we recommend it because we think it brings a better outcome to the patient? That is the only issue that I wanted to discuss.
I think that's a very important consideration, Ashraf. I think the biggest issue involved underlying all of this is that it actually results in a lower protamine dosing. As a blanket statement, I think a majority of patients get far too much protamine because people don't understand the pharmacokinetics of heparin administration. But I'm just a bit concerned about advocating a lower heparin dose as a primary strategy.
So do we need to wait until we've got proof that it reduces the protamine dose so that you can demonstrate the benefit at a time when we're advocating a type 4 circuit to suggest to people that they might use MiECT safely? They raise their eyebrows to this statement without seeing the potential benefit until we can prove it.
Well, there is a lot of questions, but we should keep on with the questions. Adrian wants to comment.
Yeah, I want to comment on it. Thank you. What we have done now is finished the trial, and what we see is that we have a reduction in bleeding of more than 400 mils over the whole time. So there is something. I also expect, or I also assume that is because of the low protamine dose, probably. So, and what we have done now from 2018 until now, we changed our protocol for the whole patients, and we have now more than 1,000 patients on that low dose heparin protocol. And yes, of course, it's not published. That's the problem also for the recommendation here. We have to publish it. Shame on me. We have to do it, and then you can also work with it. The only thing what you can do now is believe me, I'm sit here, but I do understand if you're going not forward to that recommendation now because it's not published yet. But I can say you it works, and it works safe for the patients, and we see the benefits for them.
All right. Is any other comment from the panel?
I would like to just make a comment as well. I think if you look at, I think we should be very cautious when looking at ACTs and defining ACT targets, because even the device you're using to measure ACT, and I really don't think we stress that enough. We don't look at that in these papers that the ACT device that we use to measure ACTs, they're all totally different. And some have, like, if you use Medtronic, an ACT of 480 might be an ACT of 400 and the hemocron signature. So I think, I think we have to be very careful when looking at ACT targets.
I echo that statement, absolutely. We've done a small trial looking at exactly that factor. So there's many variables. ACT is not a homogeneous issue.
Yeah, we recently did a publication in Perfusion, and it's very concerning, the difference in these.
Yes, I think we have to be very, very cautious. We don't want to cause harm inadvertently.
If you are above 300, you are safe anyway. Ofrom make a big study. It was just a cohort study, but they have more than 6,000 patients in it with 250 and an open system. Completely treatment on it, but an open system, and they see any problems with it. If you are with a mini system over 300, you never will see problems with that. You can trust me. We also have thrombine formation area under the curve, and we don't see any activation on it. If you are over 300, Bull has saying the same in 1975. over 300, you never will see thromboembolic complications.
Yeah, the only thing I want to bring people back, a little historical perspective. Those of you that were involved in any of the aprotenin studies were aware of the impact of aprotenin on ACT, C-lite-based ACT rather than kaolin. And people that were using C-lite ACTs found these extraordinarily high ACT values in the combination with aprotenin, reduced the heparin dose, and had a multitude of thromboembolic complications. So I think excessive caution in recommending ACT targets and heparin management is warranted.
The best way is to use a heparin management system. That's true.
Yeah. So I think this is a particularly, we have to be very, very careful with recommendations made regarding ACT and heparin.
Yeah.
I think the most important statement, in fact, is determined using a heparin dose response monitoring system, so that because I think the primary benefit in all of this is the reduction in protamine rather than heparin per se, if it's appropriately managed.
Yeah, that's true.
I think Alex Wachbach has an input. Yes, Alexander.
Yeah, I would just like to comment. I trust Adrian that his comments are correct. And actually, if you look at the older studies that were done in Norway in one of the private hospitals, they reduced the ACT value to 250 and had excellent results in thousands of patients. But these were excellent surgeons, and it was straightforward, simple coronary surgery. But I believe that if you use MiECT systems, you could reduce the heparin dose. But of course, we want to be careful, but I think there's a lot of evidence that would support this strategy. But you can't just say any surgery, any ACT machine, anything. But I think there's very good evidence that this is a possible way forward to reduce blood loss.
I think the other thing as well is you look at the actual bio coding, right? So heparin coated circuits, you might be able to get away with it less or more, I'm sorry, than something like balance, something like a PME coding. So it's I don't know. I think we're opening a total new can of worms, big can of worms, if we start thinking about this. Where I think we have to be very specific on, like I said, the type of circuit, not just a MiECT circuit, but a MiECT circuit with, Adrian, what were you guys using? Were you using the heparin coated circuit?
No, it's a BioLine coating. So
BioLine, which is heparin coated. So
yeah, it's heparin. Right.
Cyril, there is no MiECT without bonding. This is prerequisite.
No,
what we say here is any bonding.
This study was with BioLine, but we're also doing it with polymer coating from Livanova. So it's also working. What you more have to consider is what's with the blood staying. It's not running like the cardioplegia. Also in the coronary system. We add heparin to that system. We add heparin to the Calafiora system in order to have a high ACT in that system. So because it's staying for at least 20 minutes, sometimes longer. So such things, and that's true. You have to be very specific what you say, what we say, and what we recommend. You need a certain protocol for it. It's not just to reduce it. You have to think about it. That's true. Yeah.
Adrian, I think that's a very important caveat. As you say, you're adding it to the cardioplegic solution. I think there's a number of making a blanket statement. I think is really sticking our neck out and may cause more harm than good. I'm just very concerned about that.
Is there any other comment? So what I want to say is just for Adrian Bauer, who is very, let's say, furious on this, and I am with him anyway, because we are doing the same thing, is that in the light of COMICS trial results, COMICS has already recruited more than 1,000 cases, and there are a lot of centers that are using low anticoagulation protocols. So we will have class 1 very soon, one way or the other, and we will define this. But before that, I take the message from the panel to keep the old recommendation 2B and not advance it, so as we'll be on the safe side before we have, published results rather than anecdotal or, results that are coming. So if everyone agrees, we will stick on 2B, level of evidence B. Is this okay to everyone?
Absolutely, and I will publish data as soon as possible. Yeah.
All right.
Yeah.
Okay, good. So we agreed, and go on.
Okay, fine. So we solved the enigma, and then we moved to a statement about anesthesia. This was the previous statement that the use of short-acting opioids in combination with propofol or volatile anesthetics and hypnotic effect monitoring by processed EEG is recommended for reduction and maintenance of anesthesia for MiECT-based surgery. And this is a class of recommendation 2B, level of evidence C. And as you can see in this slide, it indicates the absence of focused studies on anesthesia with minimally invasive extracorporeal circulation. There are very, very scarce publications on dexmedetomidine or the bioavailability of metoprolol. So we cannot actually have to comment on something and we can move on safely. There is a lot of done on this field.
Just before we move on, though, Polychronos, sorry. I just think to me, the anesthesia for surgery on MiECT, I would add one last phrase. The reason to do that is to facilitate fast track recovery. And I think that would more explicitly describe why we're making this recommendation, but it also underscores one of the potential benefits that these patients can be fit for early fast track recovery because of all the lesser physiologic derangements, and the anesthetic technique should be appropriately tailored to accomplish that end, which is what we're saying. So I would just add a phrase to facilitate fast track recovery or something such as that.
Well, we can add that to do the discussion session anyway,
Yes,
because this is the statement, and yes, it will be complemented with this comment that you have already done.
Yes, of course. Yes, of course. This is included in the text, John, so we can move on to another statement about transfusion. So we had a class of recommendation 1, level of evidence A in the 2016 manuscript, that MiECT systems reduce hemodilution, better preserve hematocrit, as well as reduce postoperative bleeding and the need for red blood cell transfusion. And this has also been confirmed in large randomized studies and meta-analysis. So I don't think that there's any objection or any discussion needed that there is a class 1 level of evidence A that minimally invasive extracorporeal circulation reduces need for blood transfusion. Are there any comments?
All right. Is there anyone who does not agree with this? I mean, it's the same as the old one. Okay.
Okay.
Good. Agree.
That's fine. Then we move to the attenuation of the inflammatory response. And we had a class of recommendation 2A, level of evidence B, on a very, very delicate and a very, very confusing issue, that inflammatory response assessed by specific inflammatory markers is attenuated with the use of minimally invasive extracorporeal circulation. As written in the text, it's very, very difficult to compare different studies because each study uses different markers. But what we are trying to find is that according to a recently published study by a group from Barcelona, in a randomized study, there was evidence of reduced inflammatory response in the minimally invasive extracorporeal circulation, which has been actually confirmed in various degrees by other studies. But it's very, very difficult to compare the results. So I suggest that we give the recommendation, we keep the statement at the same level.
Is anyone who
I just
has any
have
comment?
one very short comment. I think that the paper from Baumbach et al. From 2016 in the annals should be included in this table because it is more powerful than most of these studies.
Yes, of course.
And it has, I think they have 120 patients in each group, and it is one of the, from my point of view, one of the most convincing papers regarding inflammatory response.
Yes, of course. Yes, of course.
Good. Anyone disagrees with this? Okay, can go on.
Okay, so we move to neurologic function, which is another sensitive issue, and that minimally invasive extracorporeal circulation reduces cerebral gaseous microembolism and better preserves neurocognitive function. We had a class of recommendation 2A, level of evidence B, based on a randomized trial that we have produced back in 2011, and actually we can keep this statement based on meta-analysis and the perspective of a study by Reinecke and by Freund, which show that they have results that show that neurocognitive function is preserved with minimally invasive extracorporeal circulation. In order to find differences in stroke, which is a very, very low percentage, you need to have very, very large trials, and actually this is not possible. So we can never achieve level of evidence A. That's the problem.
All right. Anyone has any comment? Does anyone have any comment? No. Anyone disagrees? No. Okay. Accepted.
Okay. Fine. So we move to the next statement on atrial fibrillation. We have discussed a lot in the previous session. Minimally invasive corporeal circulation reduces the incidence of postoperative atrial fibrillation. Class of recommendation 1, level of evidence A. And this was based on large randomized trials, and actually these statements could be preserved. We have data from El-Ezawi published in a retrospective analysis and propensity score matching on a huge number of cases that MiECT reduces the incidence of postoperative atrial fibrillation. It was a very, very delicate analysis done in this paper, but we need to mention that there is another randomized trial with 120 patients, with 240 patients randomized in 2 groups that did not show any difference. So there is some conflicting evidence, but viewing the results from meta-analysis as well, which show a reduced incidence of AF, like Cheng and like Kovalevsky, I think that we can keep on this statement. Ashrafni wants to comment on something.
I have just one comment to the second paper in artificial organs from LM. I would just add at the end of the after in the box after type 3 that the same suction strategy was used in both machines. So they actually had part of it as a cardiotomy suction. So just to clarify why a possible explanation for this difference.
Okay. Anyone else has any comment?
Can I just ask about
Yes,
the sentence regarding the ELAM paper? You say
Yes.
a randomized study showed the same results. Are you referring to the previous paragraph? I'm sorry that I haven't looked at the paper.
Yes, I'm referring that they showed reduced incidence of atrial fibrillation with minimal invasive, but without reaching statistical significance.
No. The problem is what you're citing is the text and not the table. And in the text, it is confusing because you write that they found the same results as if you're referring to my study, the same results as I showed, while actually you mean they showed the same results in both groups. So in the text, it is quite confusing.
You mean the same incident?
The same incidence. They had a 35% incidence of postoperative atrial fibrillation in the first 86 hours in both groups.
Okay, so we will clarify.
So that will be clarified in the text.
That will be clarified, yes, in the text.
Sorry, could I just ask a question? Level of evidence A is data derived from multiple randomized clinical trials. Which specific randomized trials are we commenting about?
You have the trial that I showed in my presentation, published in Perfusion 2011. There we had 250 patients in each group, and we had and it was a prospective randomized trial.
Excellent.
And we had an incidence of 16% in the MiECT group and 24% in the conventional system.
Good.
So this is actually the largest, to my knowledge, best of knowledge, it is the large up to comics. It is the largest prospective randomized trial ever done in this setting.
That was in our previous position paper
Right.
Don't forget that this is an update, so we confirm that in the light of these trials that we are presenting here today, which we have two meta-analyses and the trial that Ashraf has presented in his first talk, we confirm that we have the same class and level of evidence. That's what we advocate.
I mean, not to be a stickler, but we have multiple randomized trials, and I apologize, I haven't reviewed the literature in that extent, and certainly Ashraf's study is very, very important.
If you look at the meta-analysis of Cheng, which is pointed out here, these were all, they included, as you see in the table, 2,196 MiECTs and 2,154 conventional systems, and they only included prospective randomized trials with a case, with a group size of more than 20 in each arm. So there are several prospective.
Very good. Very
Yes.
good. Thank you very much. Excellent.
Yes. All right. So anyone disagrees with this statement? No. Agreed. Thank you.
Okay, so we move to renal function, and the statement, as seen in the previous, the 2016 paper that stays the same, is MiECT preserves renal function. Class of recommendation 1, level of evidence A. Also, I will follow Ashraf thinking there have been multiple randomized studies specifically targeted to renal function that showed that MiECT preserves renal function, and this is actually portrayed in meta-analysis in the large network meta-analysis that is reduced with a reduced incidence of renal dysfunction, while there was also another randomized study which showed no association, but it's a small study, and also they used goal-directed perfusion in both arms, and it was not that significant. And also we have the large propensity-matched analysis on postoperative renal failure and hemodialysis by Provaznik. This was the group from Regensburg, which showed that renal function is preserved. Yes.
So it's a big propensity match series from Regensburg by Provaznik last year. So is there any question for this statement?
Yes, I think the evidence is the evidence.
All right.
Is
Anyone disagrees about this? Okay, let's go on.
Okay,
Agree.
so we move on to myocardial protection, where we keep the previous statement that MiECT is associated with improved myocardial protection, which was coming from large meta-analysis. Because if you consider that there are different definitions of what is myocardial protection. If we focus on myocardial infarction, then the rate is very, very low reported in randomized studies. So if we think that we have 1 or 2% of myocardial infarction, then actually no randomized study can be adequately powered to detect a difference in that. So we were based our statement in meta-analysis. And also Kovalevsky pointed out that that MiECT was superior from even off-pump and conventional cardiopulmonary bypass in reducing the rate of myocardial infarction. And also during the last years, we had, let's say, a focus on types of cardioplegia, and that is not actually giving evidence of myocardial protection for minimally invasive corporal circulation, but the studies were focused on the type of cardioplegia. And we need to mention about this low volume cardioplegia, cardioplexiol, that the group from Bern and group of Basel are using. So the statement stays the same. I don't think that there is any need for changing it. That's the whole point of the review.
Is there any question about this statement? Okay, any objection?
Yes.
Yes, John.
I just wonder, again, I hate to be a stickler. Is this a level B? Class 1 recommendation, conditions for which there's evidence and a general agreement that a treatment is useful and effective. Level B, data derived from a single randomized trial or non-randomized studies. Is this an A or a B?
Well, according to the existing position paper, when we refer to a lot of randomized trials from the first era before 2014, it was 1 class 1 and level A. After that, we had this Kovalevsky's meta-analysis that confirmed the results and some other trials. So we didn't change it because we have the previous studies.
Perfect.
So our statement stays as it is because there's nothing new from what we have considered that time.
Perfect.
And it is based, as I say, to randomized control trials.
Yep. Okay, thank you.
Okay, that's true. So we move to end organ protection, and we keep the same statement that MiECT exerts a clinical protective effect on end organ function, and this was based on multiple randomized studies focused on lung function with specific lung markers, specific lung injury markers, on liver injury markers, on intestine injury markers, and I would like to mention Wim van Boven, who was the expert and contributed significantly to producing evidence of this field, which is related to enhanced recovery of microvascular organ perfusion, and that was class of recommendation 2A, because the studies were randomized, and level of evidence B, because we had randomized studies not adequately, not multiple randomized studies, because we had diversity of markers showing the end organ function. And I think this stays the same. What we mentioned in the manuscript is that, as shown previously in the discussion, that well-designed studies focused on microcirculation per se, and not to indirect evidence of microcirculation, like preserved organ function, like preserved creatinine levels, preserved transaminase levels, preserved specific brain protein levels. So we should focus on macrocirculation in order to understand the exact effect on MiECT or microvascular perfusion. We cite the last abstract of Serdar Güneyüddin that provides microscopic evidence of microcellular integrity. And what we actually call for a lot more studies in order to produce much more evidence. So there's nothing to change on this field.
Any comment on this?
Any comment?
Is there any objection?
No, I think it's excellent. The only thing I would like to add is perhaps we should include brain in end organ function, because as you pointed previously, there's evidence of less delirium postoperatively, a better preservation of intraoperative SAT values, brain SATs. So I think we could very readily just slightly modify it to put end organ function, including brain, liver, and lung.
Can do that to the discussion, but we definitely consider brain as an end organ anyway.
We had a neurologic, we had a paragraph in neurologic.
We have, yes, we have a neurologic anyway.
It was
previously. But yes, we can do that to the manuscript.
Yeah, end organ.
Yeah.
Yes, of course. And what about Asraf?
Yes, Asraf, you want something? No, he doesn't want. We want.
I just don't know if I'm not feeling so comfortable with citing abstracts in a position paper.
Yes.
But that's I don't know if everybody's comfortable with that. I don't want to be make myself unpopular, but
yes,
citing abstracts in a position paper, I don't think this is very wise.
Yes, of course you're right, because you are seeking the best available evidence. But according to the PRISMA statement for producing systematic reviews and guidelines, you need to search abstracts and even clinicaltrials.gov for ongoing trials, or even ask centers that you know that they have results to give you unpublished data. So you can even check this.
I'm not objecting. I
Yes,
just
yes,
wanted
yes.
a discussion so that we're all in.
You take the message from each of the papers according to its power. So you validate the abstract as an abstract, but as Polychronis has pointed out, the PRISMA statement opts for even personal communication that has to be referred. So we are just referring it, and definitely it doesn't do any harm. It just adds to our
I'm not only commenting on
strategy.
this single reference, because there are several other ones in the position paper. So
Yes.
it's
All right.
not sticking to that one, this one.
This is
in
conflict of
specific.
interest because Serdar's.
And also we're pushing Serdar to publish his results. You know,
Yeah, so-
this
yeah.
is the main
So-
message. So,
the main,
what he implies is that as long as Serdar, you do not publish your results, then there will be a lot who will argue against your results. So,
But to be honest, as soon as they are reported, they are considered as valid. I mean, you can't say if it's not published and it's announced in a Congress that is not valid. So that's it. Anyway, any objection for the statement? No. Okay, let's go on.
So we move to the hardest endpoint, that is mortality. So that this has been discussed extensively in 2014, and we ended up to the statement that MiECT appears to offer survival benefit in terms of lower 30-day mortality after CABG procedures, and it was a class of recommendation 2B, level of evidence B. I would like to declare that we cannot change this statement as long as we do not have any study adequately powered to detect the difference in mortality. So we're based in meta-analysis. We have produced a meta-analysis that shows a mortality benefit, which was also confirmed in another meta-analysis by Kovalevsky and as a composite outcome meta-analysis by Cheng. But definitely, considering that all these meta-analyses use diverse configurations, and also I would like to comment that even Professor Anastasiadis is having some concerns about the risk of bias and the methodology of the randomized and non-randomized studies that produce the meta-analysis. I think that we should be very, very, let's say, careful in keeping this statement and actually urge for producing evidence rather than considering the evidence coming from the meta-analysis. So we keep the same. I believe that all of you agree that we can keep the class 2B level of evidence B until we produce evidence from adequately powered randomized studies.
This is our modest statement, so I don't know if anyone wants to upgrade this. Okay.
And then we move to the new statement. So we have added a statement about octogenarians and high-risk populations because we have studies focusing on octogenarians and high-risk populations. So we have added a statement that MiECT offers clinical benefit in octogenarians undergoing CABG or AVR procedures, class of recommendation 2A, level of evidence B, based on large retrospective and propensity matched studies of aortic of AVR procedures versus transcatheter procedures, and retrospective analysis of coronary procedures in elderly patients, which show that there is benefit with minimally invasive extracorporeal circulation. So, could we add this statement?
Does anyone has any comment on this statement? Any objection? Okay, then agreed. Let's go on.
Okay. So we move to points of interest mentioned in the manuscript. We do not have to discuss about cost effectiveness. There are scarce studies. We just mentioned the results of these studies and quality of life and pediatric cardiac surgery. There are points of interest, but this means that they have to be evaluated and further investigated in the future. So what we're doing is that the summary of recommendations. So we keep the first recommendation that we have produced. That's a combined strategy. We all agree. It was the recommendation, the statement 1 in the previous manuscript. It's the same. The statement 2 and 3 of the previous manuscript that characterize MiECT as main and additional components. And then it's my honor and pleasure to announce that we have 2 new statements. One on the use of modular MiECT that eliminates any safety concern regarding air handling and volume management and ensures technical feasibility of all cardiac surgical procedures. And another statement about minimally invasive extracorporeal circulation and minimally invasive cardiac surgery going together and combining reduced surgical trauma with minimal body physiology derangement. And also the recommendations follow this principle. So we actually keep, we're adding the octogenarians, as you can see in class 2A, and we keep in class 2B the less thrombin generation strategy until we produce evidence that can upgrade them to class 2A. And I would like to thank you all for your
all right. Thank you. Thank you, Polychronis. What I would say is after 6 years of results, it's a pleasure that as a society we confirmed our initial statements that for us, we had some criticism at those years that we may go too far. But I'm glad that throughout the years, all the recent research really confirms what we have said. And we also included 2 new statements about type 4 MiECT and also minimal invasive cardiac surgery, which is something significant to be included in our MiECT's position paper that is now focused update. So, John, would you summarize and close the session for today?
Yes, thank you very much. I would like to thank particularly Polychronos and his associates for undertaking this very in-depth review. And as Kyriakos has mentioned, I think it's very important that we've not only confirmed the original statements that were made, but have been able to update that. And I think it's a real testimonial to the efforts that everybody is making and the reality that this type of physiologic-based approach really does result in improved patient outcomes. So I think overall, this is very good, very timely to do this. Just a small caveat, just to say that in the process, before this manuscript is submitted, we will probably, hopefully have the opportunity of just slightly revisiting some of the associated commentary that we make with each of these recommendations, because I think there may be a few things we want to modify or things we may wish to further include. But overall, a good effort for everybody. So thank you all very much.
Absolutely. This is the agreement. I think, Ashraf, you want to add something?
Yeah, I just have one or two comments. First of all, I think we should have a recommendation in there on what we expect to be reported on the circuits when someone is doing a prospective randomized study on MiECT. Because, for instance, I want to know how the blood was processed specifically. I want to know how much of that blood was retransfused. And this is something that is seldomly reported in papers. So I think that we should have some recommendation at the end of that paper or somewhere where we state what we expect as a society to be reported by everyone who's publishing a paper in this field. As this is essential in order to be able to differentiate why there are sometimes results that we cannot really explain.
Okay, good. Shall we take advantage of the two colleagues that we are honored to have with us from the task force, Philip de Sommer and Wim van Boven. Can we have a statement from your side about this paper before closing? Philip?
I would agree with what was said in general, but I would echo what was just stated, that we would probably stress a little bit more on what actually should be in the papers with respect to the circuit. Because this was also for conventional bypass for a long time a big issue, and still we cannot convince every author to do that. So I think that would be very nice to have that also included.
All right. So, Philip, since you are the president of EBCP, we will leave it to you to write a paragraph on this, and then we will revise it accordingly, because I know you are the best to do that, if you are happy with this.
Yes, I'm certainly happy to do that.
Thank you. What about Wim van Boven? Wim? Can you unmute? We don't hear. Wim?
That's better. Hello, good evening, everybody. I'm convinced that this meeting is a very good meeting, and it is summarized in the right way. I'm only wondering in what way we can convince the users worldwide to have the idea that is absolutely safe, because I have the impression that we can produce as much research as we want, but still people say it's not safe. And so I wonder, and I want to ask the group, what is needed to accomplish this?
Well, we still wait for comics to give results about mortality, so we hope we'll have it soon. As I say, we have more than 1,000 cases on board, and there is no interim analysis showing there is any concern or something that has reported to give us an impression that there is any, at any point, any safe issue.
Can I add something?
Yes, please.
That fits perfectly. The gatekeeper for the technology is the perfusionist. We have to do it. You can wish it, but we have to do it, and we have to feel comfortable on it. And I think we have to add to that paper also one paragraph to education, And I think we have to going forward with simulation and to make the perfusionist comfortable with that technology. So to my eyes, it would be a good idea to have a structured program in education for minimal invasive extrovert circulation together with simulation, and we have to start that process. And probably we can give out a certificate. So we work on it, you know that, a certificate to be a MiECT pilot, for example.
Mhm.
Yeah.
Okay, let it become mainstream.
So shall we finalize with Professor Punjabi, who is about to publish? Will he be kind enough to review it accordingly and give us, as I announced, a very nice position in early next year's online first publication, Prakash?
Thank you. Absolutely. What I've seen so far is convincing. I think that's the key. We've got to have that detailed table, and congratulations for good amount of hard work that has gone into it. And if you present it that way, then I'll choose the reviewers appropriately, but hopefully that would be a good step forward. And certainly you have absolutely my support, but it's also the content which is strong, which is what matters. Thanks.
All right. With this, I think we have concluded, and I need to thank everyone for the input and for your contribution for today's sessions. We will have a in-person meeting here for tomorrow's sessions. Hopefully, some of you will participate. The next broadcasting will be tomorrow morning to go on with the rest of the sessions of this update meeting. Thank you all, and stay safe. See you tomorrow.
Thank you all.